Dr. Dean St. Mart. You're known for his knowledge of bodybuilding pharmacology, PhD in synthetic chemistry, and product formulator for supplement needs. He is a renowned pharmacologist for his no-nonsense approach and open-ended transparency in regards to bodybuilding and the dangers associated.
And it's not just so you can take the most tren and survive. I might not want to take 600 milligrams of tren, but the guy beside me might not have any problem taking 2 grams. 2 grams could be an approved dose. You have to figure out what is each person's accepted tolerance. And for different people, I mean, if you want to win at all costs, then probably a lot of people will say, give me as much as I can take. I guess when you get into like your 50s and 60s or 70s, you don't want to have these mental deficits where you can't remember things. You can't remember good memories. So if you had a good bodybuilding career to speak, being able to remember childhood memories or even your children's childhood memories, it's a scary thing. It's a consequence of not taking something like brain health or oxidative stress of the brain very seriously. Does Mastron build the same amount of tissue as Primobolan? If you were to just take strictly Mastron or strictly Primobolan and compare them to one another, again looking at rates of genetic clearance, how everyone expresses the androgen receptor, the CAG repeats, everything else with that, a broad assumption would be, in theory, possibly, that they all build muscle at the same rate. But in practicality, the statin blocks cholesterol from being manufactured, and as a consequence, you block ApoB from being created. ApoB would be on your LDL particles. The statin is really trying to reduce your ApoB expression or your ApoB level than directly going to LDL as the root cause.
But there's a particular reason why the statins are normally having a very low success rate, right? Like you're basically just delaying.
And this is it. And this is because...
Yeah, I only have actually like 1,500 tabs up right now. It's very typical for me though.
If I was to show you a picture of what my office looks like now between the last podcast I done, I ran into issues on podcasts after where my battery would die on the camera, so I had to invest in like a dummy battery. So now I've got a cable running out of camera into a power bank. I've got a fan,
nice.
A fan on the camera. You've got a nice new Shure mic because people are complaining, complaining over the sound quality of what podcasts I'm doing. So I may as well pay back if people are going to watch. Let them have some good audio quality.
This is a massive upgrade, and we got the hair too now. That's crazy.
You've got everything. Yeah, the hair is back in full swing. I think I was in that. I mean, I don't know what we're going to talk about today, but probably hair is going to be probably one of them, considering my hair has sprouted out over the last 4 months. I was in that ugly duckling stage post-transplant when we done the first podcast where you've got all this fluffy hair that's not even grown properly.
No, I get it. Well, I mean, I don't get it yet, but I'm going to get it for sure. I'm going to get it in December, actually.
Oh, wow. Where are you going to go get it done?
Well, I'm hoping that you can sway my decision, but I am currently going to now hair time. Typical for a bodybuilder, right? Following along, see bums. I'm glad to hear about the transplant going well. I think it looks better than Ian's already.
I mean, when you look at their... Chris's and Ian's, I guess when you look at what's available hair transplant wise in Turkey, you've got lots of clinics, and to be honest, medical tourism is a big thing that's becoming very popular out there. Like when you fly into Istanbul, whether it's the international airport, there's 2 airports. The more like international based one is a little bit further out from, I think it's SAW is the code. I can never say the name of the other airport, but that is closer to their clinic. When you go into the actual international airport, the amount of people walking around with bandages on their heads, bandages on their noses, swollen mouths from teeth procedures, it's huge. Medical tourism out there is huge. That when you look at the clinics available, there's quite a lot of prestigious clinics available, and now hair time obviously have been doing it a long time, and they've got a lot of experienced doctors. I guess what I was very impressed with, like from my own personal experience, is the time that they take to go through your consultation with you. So when you arrive at the clinic on the morning of your transplant, they basically ask you what's your expectations of the new hairline, like what do you expect them to do surrounding the shape of it, the alignment of it. You can only have your hair transplanted to just above your forehead muscles. So they sort of check where they can go in terms of depth. So you're probably never able to go as low as it was when you were younger, but you can go pretty close to where it is now naturally and then develop the hairline from there.
Interesting.
And that's why I brought my wife with me, because you get guys who will just allow them to create any hairline once the hair is put in their head. But when it starts growing, you want it to grow in a natural pattern to your own hairline as it existed. So they spent about 20-25 minutes making sure I was happy with the hairline. They give you a rough outline, like we're going to fill in here, we're going to fill in here. We're going to do, you've got two options. You've got FUE and DHI. So FUE is the procedure that they do to implant the hair into a new hairline, to create a new hairline. So they put the hair into an old follicle and the hair then grows in that follicle. And then they have DHI, which they use for density, where they basically just punch the hair into a follicle to create density on the top of your head. So they discussed with me, they said the hair on the crown area was thinning, that they could do the crown area, but the failure rate is quite high. And when you look at negative reviews of hair transplants, it's always generally surrounding the crown area. The crown area. And they make you aware of this because the follicles within the crown region, if they do DHI to put a hair into that hair follicle to create density again, there's a risk that you'll kill the follicle, you'll kill the hair that's already there, or the thinning hair that's there, and the transplanted hair might die as well. So now you've lost a donor hair and you've lost a hair in the crown region, and you've just sped up your balding process. So, I mean, when you look at what causes hair loss or hair thinning, it's normally looking at oxidative stress, like what we covered in the first podcast, like enough antioxidants, enough blood flow going to the scalp, enough nutrients. It'd be like anything. If you didn't get enough nutrients to your muscle tissue, the muscle would shrink and eventually atrophy. Your hair follicle is the exact same. If it doesn't really receive enough nutrients, it's going to effectively shrink or miniaturize. And then you have all the other hormone things on top of it, like DHT, miniaturizing the follicle, causing local inflammation, an immune response. Like when we're looking at hair loss, most guys jump and go, oh, it's DHT, it's drugs, it's a high androgen level. That's one part of the puzzle. Like the bigger part is low estrogen. So estrogen encourages blood flow to the scalp. So you have to have a healthy estrogen metabolism for healthy hair. And if you sort of look at a pre-contest setting, you're doing stuff that pulls your hair in reverse and lowers your estrogen.
For sure.
And then you've got thyroid hormone imbalances. So I think personally, looking back, as my hair started to genetically recede in like my early 20s, when I got to my late 20s, when my celiac disease started to develop, or I think that's when it started to develop, you can sort of see in photos from when I got married into like my early mid 30s, where my hair was just slowly dying and moving back, that once the follicle is dead, to speak, you're not stimulating the hair to grow again. So what I wish I knew, or I guess in hindsight, I wish I was a little more less carefree with my hair, that I paid attention to a little bit more, because it was only when I see my hair, I think it was like 32 or 33, I seen a photo of myself and I was like, what's happened? My hair used to be really thick and dense. Started doing stuff like topicals for my hair growth. Started paying attention to obviously how you nourish the hair follicle, derma rolling, microneedling, all these things that guys go down the rabbit hole of doing. And I got really good density back, but the two receding spots on the side of my scalp were, the damage was done basically, so you're not getting that hair back. And it was just weighing up, well, how long do I wait to see out that recession? And so I gave it like 4 years until I was 37, well, 36 when I went for the transplant. And at that point, like I said last year, with shaving my head before the shows, you could see where the hair had receded back quite a bit. When you start shaving your head and you look at actually where the hair follicles are dead, that bald spot in your head, you see how much you've actually lost. So with like the transplant, they create the hairline, they go through all these things, like they tell you about whilst your crown area is thinning, it'll probably regrow with minoxidil and finasteride topically after the transplant. So they thought that they have a really good, I guess, cosmetic doctor who looked at my hair, even with the shaved head, and said, I can see that there's thinning in the area, but I don't think it needs a transplant. That medication will fix that problem. And I guess when you look at guys, especially when on a bald head, you can see scalp thickening. When guys have ridges in their scalp, that's scalp thickening. It's collagen deposition. So that really like brainy looking shape to your scalp when you have all the ridges in your head with a shaved head, that's impeding blood flow to your scalp. So it's creating, I guess, laxity to the hair follicle. So one of the other suggested theories of hair loss is actually loss of scalp tension. And that's where you'll get people with like scalp massages, even as far as there's some, I guess, treatments that recommend Botox into your scalp as a method of helping with scalp tightening. But that was all argued back in like the 1950s, 1960s. They argued backwards and forwards. For about 40 years, they discredited that scalp tightening theory. And it seems to be making the rounds again in terms of the research might not have been fully correct in dismissing it, that there might be something to look for there with supporting hair growth. So when they do the hairline, they go through all the risks and everything else. The hair extraction, you're lying face down. The most painful part, I've spoken about this before and other people asked, it's not painful other than the local anesthetics. So when you're getting the local anesthetic into the back of your head and into your forehead for the transplant procedure, they're about a 7 or 8 out of 10. But it's for about 5 minutes. So if you can distract yourself, like have a good pain threshold, keep your mind occupied, it's literally you feel the pain and then you don't feel the pain. So it's a really sharp sting and then nothing. A really sharp sting and then nothing. If you can sort of just put your mind, keep your eyes closed, keep your mind occupied, before you know it, it's over with. The hair extraction's fine because you're like on a massage bed sort of setup. So you're lying face down. You can potentially nap. But then the transplant procedure, sitting in like an incline chair. And that's when you probably have to pay attention to staying very still because they're obviously transplanting hair into that hair follicle with such accuracy that you're sort of afraid to even move. But towards the end of it, my transplant procedure took, I think, just over 3 hours. Towards the end of it, you're getting a bit like, I want to get out of here. I've had enough of lying about because they're working pretty much in silence. The two, the surgeon has an assistant with him. He's basically just working in silence, talking to his assistant throughout the procedure. And you obviously have your eyes closed and you've got a sheet over your face to protect you from the light that's shining on you. You just sort of like, you're just left with your own thoughts for about 3 hours, that by the end of it, you're like, I just want to get out of here. Like people sort of, I've seen other people speak of other clinics that perhaps have you watch TV or other ones, but these guys pay so close attention to what they're doing that they obviously can't afford to make any mistakes when they're dealing with something so delicate. The recovery process, I mean, aside from the pain of the local anesthetic, that's probably the hardest part, is the first 3 days or the first 3 nights, because you have to sleep upright. So you basically sit upright to go to sleep. You can't lie down. You can't bend forward. There's a lot of restrictions for the first couple of days. And once you get past, I think day 7, you can lie on your back then. But you still have to sleep with a neck pillow around your neck. So the first 10 days are a bit iffy, that you can't touch your scalp, you can't bump your scalp, you can't rub your head. And if anyone who's listening has had a hair transplant, they'll probably like attest to the itchiness that comes with your scalp, where you just literally want to rub your head, but you can't. So the itch, as the wounds are healing, obviously you get all the scabbing on your head and you wash the scabbing off. That's probably the hardest part to navigate, is getting through that first 10 days. And after that, then it's just patience. And then eventually, hopefully, end up with a set of hair after about 4 or 5 months.
And then you look as pretty as Dr. Dean.
You reverse time by about 3 or 4 years.
I'm excited. I'm glad that you said that they consult with you for a while on how you want your hairline, because I'm going to be real. I have seen some hairlines that, and I think this is a shared opinion amongst most people that like view a lot of these like reels or clips of the hair happening, but that just don't look super natural, because sometimes they're just a straight line.
Yeah, that's it.
I think that was my biggest worry, to be honest.
And like, bring your partner with you to get her opinion. Like, that's why I brought my wife. I wanted to make sure that what they drew looked realistic to her, that when it did start to grow out, it looked as I did when I met her in my 20s. So she's very happy with the result. Obviously, she has
I'm happy with the result, man.
Yeah, and I'm very happy too. It's like I said, it's very, very natural, and there's still actually, you can't really see it when I even show on social media. There's still little miniature hairs sprouting in this region. That's only going to get even more dense over the next 4 to 5 months, I'm told. So we're really only at the halfway point of how you assess the result.
Wow. That's awesome for halfway point.
Obviously, the hardest thing then is navigating after the transplant in terms of keeping the hair that you've transplanted in. So, like, they will advise that you avoid any type of hormone replacement post-transplant for 4 weeks. If you are prescribed under your doctor, consult with the doctor, obviously, around potential hormones that you might be using. And then after the 4-week healing period, you're allowed to resume your normal medication if it's prescribed. But they cover basically all the like what if scenarios. You have a translator who's available at all stages of the journey to speak. So the surgeons do speak Turkish, but you have a very good English interpreter who will tell you what they're saying to you, and you can explain back what questions you may have or what concerns you have. Even throughout the surgery, you have the interpreter coming in and out of the room asking you, like, is everything okay? Have you got any questions? You know, is there anything you want to know about during the surgery? Which is always a positive thing, that they're checking up on you. And then the aftercare, I mean, every month they've checked in asking for, you know, a WhatsApp. Do you have an advisor on WhatsApp who follows up with you every month? Like, you're now 1 month post-transplant. Can you send photos for the consultant to review, please? And they've done that pretty much now. We're into, this is month 5. So for the last 4 months, basically, pretty much bang on Thursday when it falls to the new month, I get a WhatsApp saying, please send the photos, and the consultant will assess, you know, how your treatment or how your recovery is going. But I think as the next sort of few months rolls on, it's probably just going to be more formality than anything really going wrong.
Mm-hmm. Right. So I guess regarding minoxidil and finasteride, is that something that they like to implement afterwards?
Yes.
I know you were mentioning the crown area specifically, but
yeah, so they give you obviously a post-operative care, I guess, treatment plan, if you want to put it that way. So they'll give you like a medicated shampoo that's to be used for 4 to 5 months. They give you various different, probably the best way to describe it, like nourishing oils that would be like olive oil based with vitamin E and all these other nice extracts to help nourish the hair. But then they do obviously recommend that you either use oral finasteride or dutasteride or topical, depending on your preference. And to use it in conjunction with minoxidil. There's, I guess in recent times, we've seen a lot of, content around like post-finasteride syndrome or potential issues that can arise with finasteride use, which is completely warranted. Like, it is documented that it's not something that is like psychosomatic, that's in their head, that they think that there's these problems. We can see in guys who develop these dysfunctions, issues in their blood work, or if they do a dry urine test for hormones, a Dutch test, you see changes in their estrogen or their DHT metabolism. So when we look at what potentially could happen with the use of these things, it can fall down to a couple of different points. When you inhibit the 5-alpha reductase enzyme, depending on what you do with that enzyme in terms of inhibiting it, the 5-alpha reductase enzyme and the aromatase enzyme rely on NAD energetics. So everyone's heard about NAD+. So in order for those enzymes to work properly, they require NAD to facilitate the enzyme doing its job. So when we see issues with post-finasteride syndrome, potentially the enzyme has been stopped from working functionally. So in theory, we have blocked that enzyme from working with a drug. And then when we start to reinitiate the drug or reinitiate the natural process of the enzyme working again, there might not be enough energy substrates available for the enzyme to work properly again. And what you'll often see with guys who have potential issues with post-finasteride syndrome, that there could be issues surrounding their mitochondria, with their NAD, with their overall cellular energy metabolism. That it's never a case to say that it's in their head or that it's a neurotransmitter imbalance to speak. I always go back to like step one, and where do the neurotransmitters get created? Where's the energy for cellular metabolism created? You go straight back to the mitochondria. So for guys who are listening and they have potential PFS, start from step one with the mitochondria of they're the guys that make your neurotransmitters. They're the guys that make your sex hormones, like testosterone, that then leaves to convert with DHT in 5-alpha reductase or creates estrogen in aromatase. So in that instance, you then have to look at where is your cellular energy potentially being diverted to in your body. Is it to facilitate your body staying alive versus fueling this enzyme to do the hormone conversions? And when you start thinking like that, in terms of if there is an energy imbalance, what's your body going to preferentially use NAD for? To fuel ATP to make your energy, or to fuel an enzyme that makes DHT that, in theory, if you're making testosterone in your mitochondria, your body, to speak, is being fulfilled from a sex hormone perspective, although it doesn't have the same binding affinity as DHT. It's not going to put as much importance over cellular energy production. So guys then can pay attention to perhaps what is limiting NAD from being made in their body. How is their overall carbohydrate or glucose oxidation operating? How are they oxidizing fatty acids? In theory, they might see some benefit from NAD supplementation, but the problem is when you give the body NAD, you're putting all this substrate in, and then you're hoping that the body's able to recycle that substrate properly. And when you look at, without getting into all the boring biochemistry, when you use NAD up, you've got other things that have to feed in to get it to recycle back to NADH to fuel NAD plus again. It was things like vitamin B1, vitamin B2, vitamin B3. Like, looking at the bigger picture, that an IV drip of NAD might help you feel better for a few hours, and that actually might make you feel worse if you don't have those underlying things supporting the energetics of what recycles the NAD. So
right. So like vitamin B complex in the morning or something, like say that you're injecting NAD plus with taking that supplement. Would you find that beneficial?
With NAD plus, I mean, a little goes a long way. Whether that is with NAD plus straight up as an injection form or an IV, whether that's through nicotinamide riboside, NR, or nicotinamide mononucleotide, NMN, you're basically just giving the body a convertive source of NAD. So when you're doing this, you have to think, if I put this in, what else needs support around it? And with the mitochondria, you've got the complexes of the electron transport chain, and each complex uses a different substrate, basically. So if you push a lot of NAD in for the first complex to work, the other guys have to pick up, and that's where feeding in, obviously, the B vitamins, more so riboflavin, which is B2, which is what you use for FAD synthesis, which is another complemental type of donor like NAD. And obviously vitamin B3, niacin, is what eventually converts to NAD in the body. The vitamin B1 is more for helping with carbohydrate metabolism, so thiamine. It's very important for our body to utilize sugars for energy. So an activated B complex would be a useful thing to consider, but bearing in mind that if you're using an activated B complex and you're putting in a lot of folate, metal B12, pyridoxine 5-phosphate, everything else that's in the methylated B vitamin or the activated B complex is feeding into other things as well. So this is where like taking supplements can get complicated, where someone takes a supplement and expects it to work in a certain way and has a completely different effect. Like if someone has issues with methylated B vitamins, and we see that carry over to methylation and potentially clearing out neurotransmitters too fast, or slowing down their neurotransmitters being cleared, you're going to see symptoms like maybe overstimulation, or the other side being very anxious, and they're expecting this methylated B complex just to give them energy. Someone told me B complex is great for energy, I'm going to take it as a supplement. That you have to really think about, when I put this into my body, what effect is it going to have downstream?
Gotcha.
It's food for thought when you think about like taking different supplements, expecting one thing, like someone takes a B complex, expecting it. Even general population, people are led to think that B complexes are all about improving cellular metabolism, which they are, of course. But then the other impacts, like what we discussed on the first podcast about vitamin B6 and dopamine conversion and serotonin conversion, these are other things that are outside the energy metabolism, that someone takes these products and then they experience these side effects without ever being told that these could be a side effect.
Yeah. This is another reason that I think is just so valuable for a lot of people to, I think, dip into this space and listen to figures like you, because it just shows how much biology, neuroscience, just even steroid use and bodybuilding, everything, all of it is so individualistic. But when you like zoom out and look at the general population, I think there tends to be a very easy generalization of a lot of things. Such
absolutely.
as all men are misogynistic. Just a lot of different things. Just a lot of generalizations all the time. But I guess the good thing though about the finasteride, post-finasteride syndrome though is it only maybe like 0.3% or so of the population that does end up actually having that side effect.
It's a very small percentage, but like anything, there's always going to be risks with any medication that's used. And that's where when someone chooses to take a medication on obviously the advice of their general practitioner, their conventional doctor or whoever, healthcare practitioner, that they understand that whilst medicines can have positive effects, they can have most definitely negative effects. And it's it tends to be when the negative effect gets blown out of proportion that people then see a fear to a medication. Mm-hmm. And then it's sort of maybe potentially sidelined when, if we then do like the sort of molecular biology approach, we can figure out why that dysfunction has happened. But the problem then is most conventional doctors unfortunately don't have the time to delve into a complex issue like mitochondria energetics or enzyme dysfunctions. When someone presents with these side effects, it can almost leave them thinking, well, maybe that person's just depressed, or maybe they're overly anxious, or maybe they're overly stressed. That's why they have no libido or no drive. That it's got nothing to do with a lack of enzyme kinetics or the mitochondria or everything else, all the nitty gritty stuff. And that's where, unfortunately, the past guys were probably told it was in their head, until enough guys started speaking out and people start to actually think about potential solutions on how we can address it. And I mean, 5-alpha reductase inhibitors are only one piece of them. I mean, I see this with aromatase inhibitors, where the aromatase enzyme becomes dysfunctional from an energy perspective after using chronic dosages of AIs. And again, that's not to say that every person's going to develop this, which would be incorrect. But again, that is something in terms of the enzymes machinery. If there is a lack of energy being contributed to the enzyme, it's not going to work as efficiently as it should. And I've seen it with Roaccutane, where Roaccutane has acted as an inhibitor of 5-alpha reductase, similar to finasteride, leading to symptoms of post-finasteride syndrome. And you see guys talk about post-Roaccutane syndrome. But again, doing a level of groundwork, investigative work, looking at organic acid testing, the Dutch test, looking at all these functional tests that might give us an insight into how the body's creating and using energy, you can potentially get an answer there to figure out how can I fix the problem that has recurred from using this medicine. I wouldn't say it's something that you take and you're doomed and gloomed forever. It's just something that takes a bit of time to figure out where the actual root cause is lying. And the other side of it, I guess, to be a bit fair on it, is to not let it play into your psychology. Because if it does start to play into your psychology, we know the power of the placebo, that your mind is very powerful at what it can perceive and create in our environment, that you don't want that to be compounding as a problem on top.
Right. And then add on top of that after your transplant, you have to have 4 weeks off of all substances. That's
training. Put that in the grave. I mean, it was one of the most epic rebounds, and I started training again. Obviously, muscle memory and going back to a more optimized hormone environment, still being physiological but more optimized. The rebound, to speak of regaining your physique back from the dead and regaining your strength. And I guess, I mean, during the 4 weeks off from training, I lined up a lot of different projects that I just buried myself into. So if you can't train, if you've got a surgery and you can't train, or something has hindered it, find an outlet where you can invest the time that you would have spent training into something that maybe you've been putting off. We wrote a scientific paper, me and two other guys, Dr. Guillermo and Dr. Lucas, for the Strength and Conditioning Journal. We wrote a paper together on that, and that took a good chunk of my time to write. So when you've got an anticipated downtime, I guess that's why I put off obviously getting the transplant done until I was very, very certain I was not going back to competitive bodybuilding. That to me, that ship had sailed, and that sort of draw to go back to doing anything like that ever again was completely finished.
Well, someone else who told me that same thing about the rebound was Terrence Ruffin, because he just got his transplant this last winter too, and he had to take can't remember, I think it was at least 4 weeks off of training, maybe extended to 6 or so, but he had this really cool story where he actually finally exceeded. There was like a weight cap that he couldn't like get past, drop back down to weight after he jumped off of everything, stopped training, obviously deflated right after. He rebounded so well that he literally surpassed that weight that he couldn't pass by like almost 12 pounds or something like that. So, I mean, and now he's got first place at the New York Pro and the Pittsburgh Pro. So
yeah, that was an incredible package. I've been a long time fan of Terence. Very, very nice, just complete structure. So hopefully he does very well this year at the Olympia.
Yeah, I'm really happy for him and proud of him. And maybe he'll listen to this podcast too, because I know he's listened to you before at least.
Yeah, so I've spoke to Terence a few times. I mean, one of my first coaches years and years ago was Matt Porter. So we shared that experience. Obviously, he was Matt's client as well. I guess with that break from training, it's very difficult to say exactly what happens, but we know from an epigenetic perspective that with how androgens influence your genes, and we touched on this again in the last podcast, your genes don't necessarily just revert back to how they were prior to using anything. So the epigenetic control of the muscle in terms of the muscle memory is still there, that when it's stimulated again, when the androgen receptor of the muscle is stimulated again, you have all these, I guess, favorable processes happening for the muscle protein to start growing again, or growing back to the size that it occupied before. So you don't lose the satellite cells, to speak. That it's always like that argument with naturals that have used stuff and then they put this sort of 7-year ban where you can't compete as a natural athlete having used anything, that you still have the potential to grow that muscle mass. It might not be as much as when you're on, but it's still going to be at a higher advantage of someone who's never exceeded their genetic limits of where their natural androgen receptor expression was held as a natural athlete. And that is something that sent me down like a rabbit hole with the book I'm writing, that if we know these things work epigenetically, what's to say then that you're not going to start breeding athletes down the line, in that you're passing your genetics on to your kids, and so that epigenetic control, you're effectively, if your epigenetics have been more favorable towards muscle protein accretion, or changing the fiber type of your muscles in terms of like the actin gene expression, everything else, when you have a child, you're passing your genes to that child, but you're also passing your epigenetic tags. So if your genes are expressed in a certain way, you're passing that genetic expression to your child. That's probably one way of explaining why you often see elite athletes follow a familial patterns, the epigenetic expressions being passed on hereditary. That you might have a very good amateur level bodybuilder, but never really gets to the level of being a professional, might aspire to, but might never get to that point. And then they pass that genetics to their child, and the child becomes interested in bodybuilding. You've, in theory, potentially given that child a head start with that epigenetic influence.
Yeah.
And at best case scenario, if they don't become bodybuilders, you might have actually influenced their natural ability as maybe a track and field athlete, or a strength athlete in a strength sport or combat sport, that secretly you've influenced your progeny with your choices of what you've chosen to do with your body.
Wow, that is interesting. That is awesome. Have you seen Chris Aceto's son?
No,
recently?
I haven't. No.
Real quick, guys. So while I was looking at the YouTube analytics, I actually saw that 85% of you guys that watch this channel are not subscribed. And I want to ask very little of you guys, but if you enjoy this podcast, if you find value in it, then please do me this one favor and subscribe to the channel, because doing so helps me get bigger and greater guests like the guests you are listening to today. Also, this channel is not sponsored. which means only the companies that I work with, which are Young LA and Huge Supplements, are the companies that can help fund this channel by you guys using the code NILE. So code NILE gives you a discount of 15% off of Young LA, and code NILE also gives you a discount of 10% off of Huge Supplements. And if you decide to purchase anything from any of these companies, it will help immensely for me by using my code. And this way, I can travel to other guests and also upgrade an equipment to make this podcast bigger and better for you guys. You should, I'm trying to remember what his username is, but you should check him out. He's, I believe he's natural. He's 19 years old. He's a natural bodybuilder. And for natural, his physique looks phenomenal. So much that there is, of course, a couple comments that are not believing that he's natural and discrediting it and stuff. But I mean, if you look at his physique and all, like, it's got that natural look to it. Does that say really anything? No, but I mean, considering Chris Aceto and his stance, right? And he's at his prime. I feel like you would have to be really calling both of them liars when, I don't know, it's just,
I mean, and then
it seems less logical to me.
There is potentially an example, but it's not uncommon. You look at, again, sons of great historical bodybuilders like Lee Labrada and Hunter, Sergio and Sergio Jr., that you have this great example potentially of how the genetic line falls, and then how that genetics, it basically carries the next generation. Because when you look at the physiques of the two children, it's surpassed what the parent has passed on. Albeit, you know, we have advances in training, nutrition, supplements, whatever else. It's a completely different physique, a much more heavily muscled physique. Which obviously there's other things to consider on top of, but it gives you food for thought that if you're just an amateur bodybuilder doing certain things with your genetics, and then you have kids, what advantage have you given your kids over other kids in the school whose parents might not have done certain things? That it'd be interesting if you start having these ethical discussions on, you know, oh, your dad was a such and such a bodybuilder or whatever, strongman athlete. You're not allowed to compete because of your genes have been influenced. Like, you start really questioning, well, what is natural? You know, if you have a child of an enhanced person with potential genetic control, is that child natural to speak because they've inherited your expressed genes? And that just sent me down a rabbit hole when I was trying to figure out long term what we're doing as a species, like as humans, what we're doing in terms of expressing our genetics in certain ways and passing that down to our kids. And then they're obviously passing those genes down to their kids. Whilst we sort of look at like the 300-pound bodybuilder as being the pinnacle or the sort of cap of the human physique, like, are we going to see someone on stage at 300 pounds absolutely inside out shredded? As we continue going down in terms of that progeny and, you know, great grandkids and everything else, depending on what has been done with parents and the children, obviously we could be heading towards like superhumanism is a way of putting it. And that is obviously something like the enhanced games are very interested in, is like creating a superior athlete with all forms of enhancement.
Speaking of the enhanced games, Chris Bell reached out to me in the DMs asking me, telling me that he thinks that I would have some valuable input for the enhanced games and would send them my way, and referred to the doctors that I have on my show. And I'm pretty sure that you're probably at the top of that list.
I was at the conference in December for the enhanced games where it was very, very, very interesting discussion. Is it something that will go ahead? I think so. And obviously there's announcement tomorrow in Vegas surrounding the announcement of where the first games are going to be held. Whether it will go through to full fruition, I guess there's a few things that still need to be figured out. Obviously there's safety and health and ethics But one of the things that really opened my mind it was basically a debate. You got the 40 best doctors, scientists, pharmacologists, whatever, into Oxford with Aaron and Dr. Dan Turner.
That's where you got all those super professional pictures of the conference.
Yeah.
Right?
And
those are dope.
Basically got us into one room and debated all of our different backgrounds and what we considered, appropriate, what we'd consider like things that should be cautioned or thought about. And again, that was what I raised at one of the debates, was this whole thing about genetic influence, that if you're a PD using athlete and you would then have a child and you've used these compounds, have you created, the next lineage of superior athletes from what you've used without, as crazy as it is, without the consent of that child coming into the world, you've already enhanced their genetics. I mean, stuff like, we were in a debate on internal versus external enhancements. And I remember going into it thinking, what level of expertise can I add to this debate? They had like 4 of us at the top of the room and then everyone else around the discussion table about external enhancements. Because I was trying to like think in my head, what would I consider an external enhancement? And all I could really think of was like, as crazy as it sounds, stuff like AI technology, like Neuralink or enhanced retina vision, crazy things that seem far-fetched, like science fiction, but will most likely become a reality. That other things like runners, we don't even think of runners as an enhancement, but you look at the top level marathon runners, 100-meter sprinters, they all have specialized runners to like shave seconds off their time, the clothes that they wear, wind sheets, whatever else. That when we're looking at like the future of enhancement, it's not just compounds. Like people think, it's just take a load of steroids and throw a load of people onto a track and see who can throw the rock the furthest or whatever. It's like how as a species, how can we enhance the human life form to speak, to have superior athleticism or superior dexterity? You look at something like Olympic shooting down the line, what's to say enhanced games don't have guys that have enhanced like optic nerves or contact lenses that basically tell you, you're off aim by 2 degrees, readjust and shoot. Now we think this is crazy, but this is the sort of things that they want to see what we can do as a human to surpass what was done in the past historically, when there was like brakes put on athletic abilities. Yeah. So it's interesting. It's not just see who can take the most tren and survive.
We already have that.
Yeah. I mean, when we went to myself, Vigorous Steve, Victoria Falcar, we were able to bring obviously a level of personal experience being within like the bodybuilding trenches and what practices go on. And I mean, it's very interesting to see the other perspective, because you had people from WADA, you had medical doctors, you had consultants, endocrinologists, that when we start getting into the discussion of things that are done just with bodybuilding as an example, it's so far removed from what they understand from research. And I mean, one of my counterpoints during one of the debates was, how are you going to pick acceptable dosages? I mean, one of the things that came up in the discussion was that like the athlete's decision is final. Like there's a whole chartered code of what we all agreed on, like the rules and ethics or conduct code. That I might not want to take 600 milligrams of tren, but the guy beside me might not have any problem taking 2 grams. Like but 2 grams could be an approved dose. That you have to figure out what is each person's accepted tolerance. And for different people, I mean, if you want to win at all costs, then probably a lot of people will say, give me as much as I can take. Which is probably not the best way to approach it, but
maximum tolerable dose.
Yeah, maximum tolerable dose. But then you have to figure out, well, your maximum tolerable dose from a psychological perspective or even physical perspective could be completely different to the guy beside you. How do you standardize that? How do you make it fair then? Because you've removed one aspect of cheating, but then it can become a free for all. That if it is standardized dosages, where's the tolerance limit?
Yeah.
And then the other side to it was, well, we'll pick studied dosages. So, for example, studied doses of testosterone have gone to like 1,000 milligrams. So what, we're going to approve 1,000 milligrams as a safe dose for every male to use, when 1,000 milligrams could have someone's total testosterone level from a UK measurement. I'm not good with doing US off the top of my head, but it could be like 200 nanomole, which probably, to take a rough guess, maybe 4,500 nanogram. You know, and you've got a guy who's is a genetically superior athlete that might have a total test level of 1,000 maybe. You're allowing them to go up to 4,000 whatever without any second thought to what that's doing to our body, just because it's a studied dose.
You're right.
And it's so difficult, and I can't say how it's going to be done appropriately, and I guess that's obviously why they've sought our expertise to try and guide the process. It's very interesting, though.
It's super interesting because I think, I mean, it just throws so many complexities because, of course, like you were saying, the individualistic response per person. But I think it also, I mean, I'm sure this is something you guys already discussed too, but like tailoring the most optimal dose per athlete per sport, whatever they're competing in, like, you know, obviously going up to like a gram of testosterone is probably not going to be optimal anyways for a majority of the type of sports that they're going to have at the enhanced games. And, you know, that's why we have like, I guess bodybuilding and pro and powerlifting, we already have a good many years of experience in separating out what types of gear and what types of doses that we're using per sport, you know. But that's going to be a completely new field that's studied here for the enhanced games. And I guess the difficulty there too is like the long-term effects are the things that are going to be maybe a lot harder to dictate.
Yeah. I mean, what I was fascinated by was the data collection that'll come from it. You know, you have athletes who will readily give their consent for everything to be tracked. I mean, heart health, kidney health, liver health, 3D diagnostics. Basically, when you view what it actually is, it's a giant human experiment to see how we can create, I guess, protocols would be the best way to say it without calling it like a PD stack or whatever, a protocol, a medical protocol that could optimize general population health. Because when you look at the core message I got from the conference, like if I was to take away from it personally, was to improve the human race as a whole, not just focusing on athletes. The athletes are more so the willing guinea pig to see what X, Y, and Z treatment does, what effect it has on to, again, motor control, neural health, strength, whatever we do in the sports. And then how can we make that research, accessible to the public to then basically look at what effect it had in an athlete and then thinking, oh, I'd like to do that personally, or I can have that discussion with my medical doctor about a potential longevity treatment. And that's pretty much the core message I got was, how can we start making people superhuman?
Well,
And we're probably just at the tip of the iceberg as bodybuilders with creating muscle mass, and obviously with strong men, I guess weightlifting athletes. We're really only touching the surface of then what are the other things that can compound on top of it, as I guess treatments, if you want to call them that.
Yeah. It would be so interesting too to me I guess this would help also expose just a huge data pool of the genetic variance in responses to PEDs. You know, you'll be able to see people that really excel a lot at the use of PEDs, and then people who probably don't really improve that much.
Yeah, I mean,
because of whatever negative repercussions. I guess
you could look at, like you've seen in recent time, people go on about CAG repeats and the efficiency of the androgen receptor binding to compounds. We might end up seeing some level of data that they can delve a little bit further and see, can they almost predict who the elite athletes are going to be when they're born, if they have their genetic sequenced immediately. And then I guess long term, to me, when we touched on genetics the last podcast, the thing about knowing your genetics is that it's not written in stone. Like if you have genetics for heart disease, it doesn't necessarily mean that you're going to develop heart disease. It means you are at risk. But depending on how you live your life, your lifestyle, your nutrition, sure, if you have a genetic issue where you make more cholesterol naturally, yeah, it's probably not going to be something long term that's going to benefit you of not having heart problems. But it doesn't necessarily mean that you're doomed to have a heart problem. And that's where I feel if we're able to sequence that elite athlete, not an elite athletes, that the bodybuilders that potentially might not have had amazing genetics to speak, but then proved themselves with hard work, dedication, intelligent training, nutrition, some PED usage. If it becomes that strict surrounding your genetics dictate how you can become an athlete, it gets very, you're not being very inclusive is probably the correct way of saying it. You're pretty much writing someone off based on their genetics if they were screening everyone as an athlete. So I think, there's pros and cons, and quite often not knowing your genetics it can often be a good thing because it's a level of ignorance is bliss. So you're not worried about X, Y, and Z thing that's found in your genetic analysis. I mean,
right.
From personal experience with my genetics, we touched on it again the last time. My genetics show that I have ApoE2 and 4, which are basically ApoE is the lipoprotein that carries cholesterol into your brain. So ApoE is associated with Alzheimer's disease and dementia and cognitive dysfunction. And when you have 2 out of the 4 variants, you're at like 50 to 60% risk of developing Alzheimer's or neurodegeneration when you get older. And this has occurred familially with grandparents. But when you look at what potentially can be done to offset neurodegeneration, what can offset that ApoE carrying of cholesterol and fats into your brain and plaque formation, just because you have that 50% risk, you don't go around living your life worrying that, okay, when I'm 60, I'm going to have a 1 in 2 chance of maybe having some form of neurodegeneration. If you were to think that way all throughout your life, you'd spend more time worrying than experiencing or enjoying life. So the genetics, when you do genetic testing, they are right in saying that you have to have a level of emotional stability to understand what's being said to you, but not sort of take it that it's written in stone.
Yeah. I think that's always super, super important. But it can be hard in this field, especially when you're doing something risky like bodybuilding. I mean, depending on who you are.
Absolutely.
But, do you feel like, is there any, do you know of any altering of epigenetics with neurology in the brain? Say that someone jumped on PEDs and then curious if that might ever, I guess,
so
occur in their offspring.
I guess in terms of genetics with neurodegeneration, neurodegeneration's a consequence of oxidative stress. Again, we keep coming back to oxidative stress, but when we experience neurodegeneration, we've either poisoned the nerve to speak with too much neurotransmitter. So you can have excitotoxicity, which is exciting the neuron too much, and the neuron just basically fizzles and doesn't know what to do, and eventually you kill the nerve.
Would you say like living a lifestyle that's too dopaminergic over a long period of time be like one potential cause of that, or is that something different?
I would say more so probably from dopamine deficit symptoms, most definitely. Okay. If we look at, I guess we'd have to split out what all the different neurotransmitters do in our brain. So if we've got dopamine being the main like driven neurotransmitter, you've got acetylcholine as your main memory forming neurotransmitter. And then you've got serotonin and norepinephrine. Norepinephrine plays into your concentration. So norepinephrine and acetylcholine sort of work hand in hand with one another. Acetylcholine helps with consolidating memories or helping with memory formation when we're trying to learn something. And norepinephrine is what keeps you engaged to want to learn something. And then one step back is dopamine, which is motivating you to want to learn something. If we're looking at what potentially could happen with like PED usage with anabolic steroids, in one instance you could cause an excessive amount of dopamine to be made in your brain. You damage those dopamine neurons long term. And that's where some of the rat studies show potentially that things like 19 Nors are neuron toxic. And that although it's a case study, or I guess a cohort analysis where they looked at, as far as I remember, they were college level PD users and looked at their memory, I guess their subjective memory prior to using PEDs and after using PEDs. And the guys who used PEDs and 19 hours to speak showed deficits in their memory versus prior to using them. That would then tell us, well, there has been some level of neuron loss or potential choline or acetylcholine deficiency forming where they're not able to form memories correctly or process or bring memories forward from their brain, which is obviously the neurons dying in regions of our brain where we store information. That, I guess, would one PED of itself or the group of them contribute to just one particular thing when it comes to neurodegeneration? I don't think so. I think it's sort of a global insult to the brain, to speak, as opposed to just killing dopamine neurons, killing serotonin, killing acetylcholine. You're basically just causing dysfunction in a group of neurons in a part of the brain, whether that nerve transmits dopamine or acetylcholine or serotonin. It's probably more so the area of the brain that's become damaged as opposed to the actual neurons and what information the neurons are transmitting. You know, although certain parts of our brain obviously will influence different behaviors, you know, your amygdala controlling your emotions, your hippocampal area with memories and where we're learning things, your prefrontal cortex for reasoning. Depending on what part of the brain has experienced oxidative stress, you're going to see potential deficits develop in that person's intelligence or their personality. But it's not brain area specific, to speak. Like, it's not saying taking a lot of tren is going to destroy parts of your amygdala or destroy parts of your frontal cortex. I think if oxidative stress is going to happen, it's going to happen globally within the brain. Wherever there's not enough antioxidant, unfortunately, takes the brunt. That the long-term strategy to offset, I guess, neurodegeneration are taking things like antioxidants or looking at strengthening the connections between neurons with neuron plasticity. But again, there's only so much that neuron plasticity can carry for that if you start actually damaging neurons, like what we began this with. No amount of like certain peptides like Adamax or Dihexa to speak is going to overcome you destroying parts of your brain. Basically, you're going to improve the speed of transmission of the neuron, but it's such a scary risk when we look at PD usage, cardiovascular disease risk, renal risk, liver disease. We can pretty much keep on top of with blood work and imaging and everything else. You don't see someone go in and go, I'm going to get an MRI of my brain and I'm going to track my brain every 2 to 3 years when I'm competing with bodybuilding of what effect is the exposure of these PDs causing to the neurons in my brain, like what parts of my brain are becoming dysfunctional, where am I potentially seeing small little lesions form in the brain from oxidative stress. That it's scary when you think about that. What you do in your 20s, you might not necessarily feel that neuron deficit because of when we're young, we have billions of neurons in our brain. It's only when things from a cellular perspective start to slow down as you age that it could start off as simple as something as forgetting where you put your keys all the time, like your short-term memory, forgetting people's names or places, trivial things. Guys are going to start getting a bit angsty here of, oh God, I forget this.
All of us right now.
I'm going to say myself included. I'm horrible with remembering names. But it could start as something as simple as that, where you don't think about it. You just think, oh, that's just normal. I forget where I put my keys. But in theory, that could be signs of slow onset neurodegeneration that you're not aware of. And that's why it is very important that with this community that we do have these conversations about mental health and neuron health as a big thing to consider when we're also focused on not dying of like more public things like heart attacks or kidney disease or a small extent liver failure. They get all the attention. They're all like, what are you going to do about your heart health or kidney health or blood pressure when you're using PEDs? And the brain is sort of like a second afterthought that I guess when you get into like your 50s and 60s or 70s, you don't want to have these mental deficits where you can't remember things. You can't remember good memories. So if you had a good bodybuilding career to speak, not being able to remember that, not being able to remember childhood memories or even your children's childhood memories, it's a scary thing to consider that you get to that point and it's a consequence of not taking something like brain health or oxidative stress of the brain very seriously.
Yeah. So we were sorry, I went down a little dark rabbit hole. You're like talking about like forgetting childhood memories, and I'm like, I'm glad I forgot those already anyways. But not trying to get a little too dark. We're discussing oxidative stress being probably one of the most important factors when it comes to all of these situations, right? Cardiovascular health, renal health, your brain. And I think this is something that's like discussed a lot over bodybuilding, which I'm really appreciative of nowadays, but I feel like it's not pressed enough still. So my audience does consist of a lot of bodybuilders, whether or not they're natural or not, but I would just have to say, honestly, in general, Americans in general tend to, through their lifestyle, induce a lot of oxidative stress on themselves. And then you add bodybuilders on top of that, whether or not they're from America or not. And it's just in the extremes. So I guess this is something we discussed in the last podcast regarding supplementation. What would you recommend for the top 3 supplements for oxidative stress? And at the time, it was glutathione being first, vitamin E second, and then NAD and CoQ10 being third. As you can tell, I've been trying to be on top of my supplementation and oxidative stress from my memory. But if we're looking at oxidative stress as a whole, all the way to the foundation of the things that we should, kind of check off in our lifestyle, I guess, what would you what are all the things that we can say, just simplifying it down to like a list of all the things that someone should check off in their lifestyle. And then obviously from lifestyle, supplementation, and then obviously finally probably going to medication for us to reduce our oxidative stress as much as possible.
I guess the very top one, sleep. I mean, sleep is where, as complex as it is as a routine to humans, it's a detoxification process where we're basically, our brain has its own immune system. It has its own microglial system where it has its own lymph, it has its own white blood cells, as obviously a big blood barrier. So the blood-brain barrier, our brain is very selective at what it will allow into it to influence it. And that's why some medicines fail to have certain efficacy in our body, because it's not able to pass across this very selective barrier. So with sleep, you're allowing all of the junk to speak from throughout the day, like the lymph and everything, dead cells, everything to sort of drain out and be detoxified by the liver and kidneys. We have obviously our actual sleep process of dreams, deep sleep, hormone secretion, neurotropic factors being made in our sleep to help strengthen our neurons. So sleep, if there's one thing that most bodybuilders will neglect, thinking that, there's just some level of armor to hold with having less of it, it is sleep. Really looking and paying attention at a metric, perhaps if you wear a fitness watch or a Whoop or an Oura or whatever, your HRV.
Making sure not to wear your Oura ring where your wife sleeps.
Yeah.
By where your wife sleeps.
or a fitness watch. But something like HRV won't be impacted by someone who's beside you. So HRV is basically the time it takes for a heartbeat to occur, the distance, the time between heartbeats, basically. And what they suggest is a shorter HRV is a faster time, so your heart is beating a lot faster. And a longer HRV means there's a longer gap between heartbeats. And we're talking milliseconds. Like, you can't even measure this. So when someone's like, oh, well, my heart rate is 50 beats per minute, we're looking at like milliseconds between those 1 second beats, to say. And so when you have a low HRV, it could be genetic, or it could be a sign that you are under sympathetic nervous system stress, that you're not getting enough sleep, that you might perceive that I operate fine on 4 or 5 hours of sleep, but really underneath the surface, your body's telling you, I actually need more to function better. And one of the things that, again, coming back to androgen's influence on dopamine, trying to stay asleep when perhaps you have a heightened hormone environment, it can be difficult. So you often find, if you're on prep, very rarely, if your recovery is pretty good on prep, you don't have an issue getting out of bed in the morning, or you don't have an issue of motivation to get out of bed in the morning. You get out of bed and go and do fasted cardio or do whatever you need to do. If you're a business owner, getting up early hours in the morning to do whatever needs to be done ahead of your day. But that drive to have a lack of sleep, to speak in terms of like 5 or 6 hours, is enough for me. And how I feel, your HRV could be telling you something different. But the other side of the argument, and this is why I hate sleep trackers or things like that as a ruler of your sleep, they could be completely wrong. If you wake up after 5.5 hours sleep and you feel amazing, and you feel amazing all the time, who's to argue how you feel versus what the research is saying on 7 hours being more optimal? And again, it's just the generic variance of people's biology and their habits and rituals and everything else. But there is some trade-off that if you are sleeping less in terms of like 5.5 hours, and this is like sleep time as opposed to time in bed, maybe see what effect trying to get 6 or 6.5 hours of sleep time will yield to your HRV or to your overall recovery. Because in the long term, you're looking at this sort of future protection as opposed to like the short term energy gain that you get from a 5.5 hour sleep. You don't know long term what that could be doing to your brain. So sleep, it's a difficult one because it's rooted in what you do prior to going to sleep, like what we talked about, but also then how you stay asleep, your underlying biology and your neurotransmitters, that if you're not capable of staying asleep from that dopamine drive where really you should be staying in bed. Let's say you wake up at 3 a.m., no problem, and you wake up at that time every single day. But in reality, sleeping another sleep cycle to maybe 4:30 a.m. or 5 a.m. might serve you better long term. In the short term, the 3 a.m. awakening doesn't disturb you, doesn't create any problems to your natural day-to-day energy. But long term, that extra sleep cycle, or that extra 90 minutes of sleep could have helped with brain detoxification further, or helped with neuron development, like neurotrophic factor release and everything else that I hate saying you have to sleep for X amount of time because it's so variable, but pay attention to when the research is saying aim for like 6 to 7 hours, try and achieve that number. Yep. You will get away with 4 and 5 hour sleeps. We've all done it. And that sometimes is 4 and 5 hours in bed, because again, with sleep trackers, that's probably the beauty in that it can tell you when you potentially went to sleep. And similarly, we've probably all experienced times where we've gone to sleep, your tracker is telling you were asleep, but for the whole night you sort of felt consciously awake. You didn't feel like you ever went to sleep properly.
I hate that.
Yeah, it can give you an insight into, okay, well, maybe I did sleep, but just mentally I was so consciously aware of my environment that I personally don't feel like I've slept, but it's telling me I have. That those nights when you have that type of sleep, again, is that the most conducive to your immune system of your brain, to your memory formation, to the nourishment of your brain. So sleep, it's free, aside from having, a bed and a warm place to speak, or a safe environment is how I put it.
Right. And the time, I think, is also what most people will discuss is difficult for them.
That's it. I mean, playing to your chronotype, similarly, like if you're, a late owl or an early bird, there is no right or wrong. And depending on different stages of your life, you might be 2 different types. You might be, night owl at one stage of your life in your 20s, and you could turn into an early bird in your 30s and 40s that just, like anything, listen to your body. The same with bodybuilding, you listen to what your body's telling you with recovery and everything else. So it's sleep sort of nailed. You're getting your deep sleep. You're sleeping in a warm bed or a cool environment is probably the better way of saying it, that it's not disturbing your sleep. The next thing probably to step up in terms of offsetting the oxidative stress is probably nutrition. Making sure that we're covering the basics, which I don't really need to go into, with micronutrients, and making sure we're fueling the brain adequately. Like, the brain uses quite a lot of glucose. So when we look at what energy sources it uses quite a lot of glucose, but also uses fatty acids.
Do you mind if I pause this for a second?
Yeah, go.
Yeah. So before we move to nutrition regarding sleep, so I know we already discussed a lot about sleep in the last podcast, including some supplementations, and I guess preventing catecholamines from raising too high whenever you are trying to go sleep. I guess, what would you feel? Because you and I both already discussed, like, one of the issues with melatonin, how it varies individually per person. Some people don't really react so well. Sometimes you'll wake up in the middle of the night if you're not using something like vitamin B, B5 and B6.
5, yeah, correct.
Particularly to maintain that melatonin production naturally throughout your sleep cycles. if one wanted to take advantage, though, of just how powerful melatonin is as an antioxidant, I know there are quite a few people out there that are proponents of high melatonin dosing. And I know both Dave Lee and Martin Fitzwater are two people that do that currently. I don't know, Martin probably does somewhere around like 50 milligrams or something like that. But I guess if someone was able to titrate themselves up to that dosage where they were able to take that much, how much would you recommend that?
So historically, prior to all this, I worked as a shift chemical engineer. So I flip-flopped between a month of day shifts and a month of night shifts. Mm-hmm. And I personally, when I started talking about things on social media during that sort of journey phase of my life, I spoke about using melatonin as an antioxidant, which is a great thing to bring up because people don't ever look at melatonin as an antioxidant to speak. They think it's this sleep hormone. But if you do work night shifts and you do certain practices, like now I've got lights here in the office, it's 9:30, 20 to 10 in the evening. I've got a daylight lamp shining here to keep me awake, that I know that's going to put some effect on my melatonin, that tonight before I go to sleep, I'll probably supplement with a small bit of melatonin to help with my circadian production or release of it. That historically I would have done 20, 30 milligrams of melatonin after night shift in the morning time prior to going to bed. Knowing that, again, when I was on night shift, I do practices like this. I'd sit in front of a daylight bulb all throughout night shift at my desk to basically tell my body artificially, actually, it's daytime, don't worry, stay awake. That if you're doing practice like that where you're offsetting your own production or release of melatonin, then supplementing with it as a strategy, again, as an antioxidant for brain health and everything else that carries over from that, I've seen 50, 60 milligrams recommended. Again, there's no set amount that is going to yield a specific response like what we talked about. If you metabolize it very quickly, that's not to say that it didn't work as an antioxidant in your body. So if you do go on the high side, I know from speaking to Steve, him personally, when he doses his melatonin quite high, it leaves him very, very groggy the next day. I can't personally say it's ever done that for me, but again, it shows the genetic tolerance or the inter-individuality of what we're using that compound for in our body. That I don't see there being too much of a contraindication to seeing what's a tolerable dose, other than potentially that grogginess the next day of you've interfered with your cortisol secretion the next morning to wake you up. But I wouldn't have any like secret recommendation to start at 30 or 50 or whatever. 20 could be enough. I mean, even trying to track melatonin is a difficult thing. The only tests that I'd encounter day to day would be the Dutch test would have your waking melatonin level. And what you're trying to do there is correlate the waking melatonin level to your cortisol, but also to potentially your serotonin, knowing that melatonin, that morning melatonin level has probably come from serotonin conversion. So I wouldn't have a strict recommendation, being fully honest on it. It's one of those ones that it's like an experiment trial and see where you sort of sit. But again, even with those large doses that I personally done, I can't say that I felt any like brain health benefit to speak, like short-term brain health benefit. Most probably definitely a long-term benefit where I've helped with my overall brain oxidative stress and keeping that under control with that exogenous supplementation. But I can't say that taking 20 milligrams was better than taking one before bed, that there was no appreciable difference between the two for me personally.
Gotcha. I think my interest comes from just how I am right now, for example, which I think a lot of people in my audience probably are, is I feel like I'm about maximizing my doses on my NAC intake, my glutathione intake, and a bunch of various other, anti-inflammatories and antioxidants. And melatonin being one of the strongest ones, I've just always found I found it very intriguing that some people would just titrate up their doses to super physiological levels in order for just the long-term benefits of, it being an antioxidant. So I guess if one were to experiment with this, like we discussed how like melatonin supplementation at the beginning of the night can sometimes lead someone to still wake up in the middle of the night. Did you or would you ever recommend continuing also supplementing with something such as L-tryptophan and vitamin B5 and 6 while you're using that melatonin just to prevent that from happening?
Yeah, I mean, when you take melatonin prior to sleep, you're sending a signal to your brain in theory that it's nocturnal, that it's nighttime. Mm-hmm. But like what we spoke about, the actual thing that keeps you asleep is your brain's own melatonin, your own production of melatonin. And that's not necessarily what you made during the day from sunlight exposure. It's what you're converting from serotonin in your sleep. So yeah, most definitely augmenting what the melatonin prior to sleep is doing to get you into a sleep pattern, and then supplementing with B5, B6, tryptophan, 5-HTP, whatever way you want to get to serotonin, is just ensuring that once you are asleep, your brain has enough cofactors to the building blocks of melatonin itself. Bearing in mind that the gene that does that conversion of serotonin to melatonin is what's considered a clock gene, a gene that runs off a circadian pattern. So that it's called AANAT. Don't ask me what that stands for off the top of my head. But it's an amino acid transporter from recollection. With AANAT, you are basically converting serotonin to melatonin within a nighttime period, running off your circadian rhythm. So if someone is working a shift pattern, that gene isn't going to be as efficient or that enzyme, I should say, is not going to be as efficient at creating melatonin from serotonin when you're trying to sleep during the day of a night shift. And that is where, again, you're coming in at the angle of taking such a high dose with night shift work potentially as that antioxidant, and also as a way of trying to keep you asleep during the daytime when you should really be awake based on what your circadian rhythm would be telling you to do. Aside from that, nutritionally, from a sleep perspective, I guess magnesium, another big thing that we covered the last time, such an easy thing to control, and the impact it has over onto your neurotransmitter clearance. And then obviously a calmer brain is obviously, I'm not gonna say obviously, it's helping with the clearance of these neurotransmitters that could be stimulating your brain to wake up. So you're staying asleep for longer. The impact that magnesium can have over onto glucose regulation while you're sleeping. Like, one of the things that has to be managed while you are sleeping is your pancreas managing your blood sugar. And when you think about it, when you go to sleep, it is one of the most vulnerable times, even historically, that your brain is perceiving that the environment is safe for you to basically switch off consciousness. That it has to perceive that the local environment is safe, but also has to a sense that the internal environment is safe also for you to go to sleep, that your blood sugar is not going to crash, that you're not going to have a hypoglycemic event and fall into a coma while you're sleeping, that your body is still having control over regulation of your metabolism, your digestion, everything else. Although it all slows down in your sleep, it's still running in the background, that parasympathetic nervous system is still doing its job while you're resting. The magnesium playing over into your glucose metabolism and energy turnover, mitochondria, everything else, they're still operating while we're sleeping. So we want to make sure that you have enough nutrition to allow us to do that job whilst we're resting.
Okay.
Yeah.
I had a discussion with Austin Stout where he was saying, like, sometimes, as you grow heavier and grow bigger, and like, for example, a bodybuilding sense, oftentimes your magnesium needs increase as well. But a lot of people don't really take that into account.
Yeah, I mean, like what we covered, the milligram per kilogram recommendation is normally 10 milligrams per kilogram body weight. And so, a kilogram, I think, is 2.2 pounds. So if you sort of convert that, it's like 22 milligrams per 2.2 grams pound body weight. Which, as you get bigger, you've created more cells of your body, and more cells of your body need more nutrition. So it is one of the ones that, as you get bigger and bigger and bigger, you do potentially require more and more magnesium. And that 10 milligrams per kilogram from the research is just a starting point. You've got guys then that could need more depending on their gut health, their absorption, their stress level. The more stressed you get, the more cortisol you produce. And the more cortisol you produce, potentially the more magnesium you're using up to dampen that cortisol and adrenaline response.
Okay. So
that is a very good thing to consider, that as you get bigger. Again, coming back to sleep health, I mean, that's another nice thing to sort of consider, that is there the possibility of sleep apnea when you're sleeping, and the impact that that's having to your neural health. And if you're a bodybuilder or even someone who's just at the gym, that unknowns to you, you could have developed a laxity in the jaw or in the tongue that is collapsing back onto your airway in your sleep, especially if you lie on your back. You could be having these like micro apneas throughout the night that is effectively starving your brain of oxygen for a period of time, and they start breathing again. The impact that has on your long-term neurochemistry as well, or your neural health, aside from the lethargy, the increase in red blood cell count to try and compensate for it. If you wake up in the morning time and your mouth is extremely dry from mouth breathing or snoring, you have excessive thirst in the morning time, you're waking up to urinate more than once per night, you're in a position where potentially you are having some level of microapnea that might not be clinical, might not be enough to have a clinical prescription for a CPAP, but you might see benefit to things that help keep the jaw more aligned, whether it's mouthpieces, mouth taping, nasal strips, everything to sort of try and optimize that jaw structure so it doesn't collapse. Or you seek a private prescription of a CPAP and see what benefit it brings. And that's something that guys, again, just they could feel fatigued during the day in their off season and just think that it's a combination of training, food, PEDs, unmanaged recovery, if you wanted to put it politely. But really at night they're snoring for 2 or 3 hours in their sleep, and they're not having the most restful sleep, where their brain again is, I guess, subconsciously trying to keep you alive. But then you're starving out of oxygen for a period of time. It's waking you up, but you're not aware of that awakening for your breathing to begin again, and then you're back into another sleep cycle. But there's still sleep disruptions that you might not consciously remember, waking up, these micro awakenings, but then the next day you're feeling them. And then obviously long term, your neural health will play into it. That's another silent thing that no one, there seems to be, I wouldn't say a taboo, but a lot of people don't really want to say, I use a CPAP machine to enhance my sleep quality, as opposed to a strict medical need that you have full-blown sleep apnea. If you have high levels of snoring, you have issues surrounding Like I said, the tongue relaxing in your sleep. There's things that can be done to optimize your sleep, that what you've set to gain from correcting that is a lot better than feeling that there's a stigma attached to having a CPAP. And you see a lot of time, like guys have a resistance to going down the route of looking for a CPAP, because they think that, oh, they're loud, they're noisy, they're uncomfortable, you have to wear a full mask. There's, at this stage, we've got non-invasive, like nasal pillows. We've got like CPAP hoses that move in your sleep, that go on the top of your head, that you might not look the most attractive to the person beside you in the bed, but if sleep's your priority, and when all's said and done, the bedroom, and you put on your CPAP, who cares? So it's a longevity strategy, that guys thinking about this as a way of protecting their brain health might be something to consider, that it's not just looking at the snoring and disturbance that the snoring brings.
Yeah. I guess the one thing that I would recommend, so I haven't even tried this yet myself, but I guess the one thing that I feel like I find interest in for the people that are like me, that don't quite have sleep apnea or aren't fully qualified for sleep apnea and a CPAP, but are on the verge and do have snoring. I know they recommend that mouthpiece that you were discussing that does help push the tongue out of the airway. I know the tongue is the main issue for me, at least I believe, that causes me to snore and causes those issues. So I don't know. I think I'm sure it'll vary per person, but that's one of the things that I think I'm going to try to experiment with, and then I'll probably have some results for people, here soon. And then the other two things that I know other people have when they sleep, they have issues with, is peeing too frequently and then overheating in the middle of the night, even if you set the AC really low. I guess, do you have any recommendations for those?
So with the peeing multiple times during the night, the first thing I always jump to is apneas. So when you have cumulative micro awakenings, you're going to get to a point potentially where you have then your kidney filtration in terms of the fluid that's being managed by your body will shift, and then your subconscious, you're consciously aware now that you're awake, and some of it can become habit. So you then wake up and you're like, oh, I need to pee. You just go up and use the bathroom. And then the other side of it, if that isn't a psychological habit where you wake up and you just think, oh, I better pee just in case I pee in my sleep. You feel an urge, or you think, I'll just get up and go to the toilet and get back into bed. The other thing is low antidiuretic hormone of your body. So really what should happen as you head towards nighttime, your body's production of antidiuretic hormone will increase. It's called, here we call it antidiuretic hormone. It also can be known as vasopressin. So you do have medications that will act as synthetic vasopressin or synthetic antidiuretic hormone. And that's one of the mechanisms of how in the past people would have done like water loading prior to shows to decrease their body's ability for storing water, but also to suppress antidiuretic hormone. So now you are basically suppressing the thing that keeps water in your body, so now you're going to pee out the fluid. When it comes to nighttime, you want to have a high amount of ADH or vasopressin so that you stay asleep. There's certain things in the environment, there's certain toxins, there's stressors to our brain that can diminish ADH production. Electrolyte balance is another thing that guys tend to completely ignore with what's called nocturia. Nocturia is waking up to pee in the middle of the night medically. If you have a very high sodium diet and you don't have enough potassium, all of your fluid in theory is being moved into your vascular space, into your bloodstream. And then when you go to sleep at night, your kidneys are going to filter that excessive fluid and salt that's in your blood, and you pee it out. You can have fluid pooling in the lower limbs, in your legs, whether that is venous insufficiency, like varicose veins, where you don't have veins were operating properly to bring blood flow and lymph drainage back up your leg properly. When you lie down, you've pooled probably quite a significant amount of fluid in your lower limbs. If you think about your bladder's capacity, most likely in around your lower limbs on each leg, you can probably hold around 500 milliliters of fluid relatively easy, distribute across the whole leg that you're not going to necessarily feel. But when you lie down at night, you're lying down, your blood pressure relaxes. In theory, when you're in your sleep, your blood pressure is at its lowest point, and fluid can drain from your lower limbs back up the body to the kidneys, get processed, your bladder fills, and now you're excreting that fluid that collected in your legs during the day. If that is a root cause, well, then you can correct your electrolyte imbalances potentially. So look at your potassium to sodium ratio. Make sure that really the RDA for potassium is 4,700 milligrams. So if we say 4,500 potassium, 2,000 sodium, it's like a 2:1 ratio almost. That most bodybuilders are in the other direction, where it's more sodium laden and not enough potassium, or they're getting some level of potassium but it's not in the correct ratio to sodium. That's a way of potentially making sure that your cells are hydrated. So potassium pushes water into your cells, sodium pulls the fluid out of your cells into your bloodstream. Alongside obviously making sure you've got adequate magnesium, calcium and phosphate. They're the other important guys that do fluid management as well. Raising your legs. You see guys do it backstage all the time. Raising your legs prior to sleep, doing about an hour before you go to bed or 2 hours before you go to bed. If you've had a busy day or somebody works on their feet, you don't have the most appropriate footwear, your arches aren't properly stabilized in your foot, all the things that can sort of play into the fluid dynamics of pumping fluid back out of your leg. Raising your legs above heart level to allow gravity to let the fluid drain out is a simple strategy if that is one of the contributors to your nocturia. And if that is the case, then if you do have something like venous insufficiency or varicose veins, there's not much you can really do other than surgery or take an appropriate rest when you're on your feet to try and alleviate that fluid building in your leg. The electrolyte side of things, you can do it, diet manipulation. Environmental toxins, I mean, people discount like mold toxins can lower antidiuretic hormone in your environment. So if a bodybuilder is waking up more than 3 times per night with a full bladder, you'd start to question what's going on in the environment as opposed to what's going on in their body. You can probably correct if you're at two awakenings to pee with a full bladder. Probably the first one is that lymph drainage and fluid dynamics from during the day and the salt balance. And then the second one might be psychological. You wake up, you feel like you need to pee, you feel that you're within 2 hours of having to go to bed, so you just feel, I'll get up, use the bathroom and get back into bed. That if you ignored that psychological urge, unless it was really at you to go to the toilet, you'd probably go back into sleep again and your body would hold your bladder until you wake up again. The psychological part, very inter-individual, but nocturnal awakening is most definitely, again, something that will disturb your sleep and disturb then the quality of your sleep and the impact it has on your brain health. So once per night, I think the rule generally is if you wake once in the middle of the night, to have to use the bathroom. Again, it comes back to fluid throughout the day, electrolyte balance. That can be just put down to being quote unquote normal. But once you start going above that with multiple bathroom trips, if you think about it, you're breaking your sleep up into numerous shifts, and long term that can obviously then have a big impact on your recovery. And I mean, that happened to me personally. I got exposed to toxic mold years ago, and that was one of the ways eventually that I was able to, I guess, verify what I thought was the problem in terms of being exposed to mold and going and doing the urine test for mold toxins. But I was waking up every 2 hours with a full bladder, like full bladder, like could not, like if you were like, oh, it's some of it's psychological or it's salt balance. I done absolutely everything to try and manage that. And I was waking up with a full bladder every 2 hours, that eventually I got to my wit's end that you'd sleep for 2 hours, full bladder, go back to bed. It literally was like a clockwork. You go to bed, wake up at 12, wake up at 2, wake up at 4, and then you got up at 6. That my sleep quality was just completely ruined.
Wow. When
you start addressing obviously the mold toxicity, doing things to help with clearing it out of the body, detoxing it, that was like the biggest relief when you start to have like a full night's sleep where you don't actually get up to go to the bathroom. I think from personal experience, and maybe some of the listeners, that if you have like a night of sleep where you don't wake up to go to the bathroom, it's like success. I've had a night where I've not had to get up to use the bathroom. You've had like complete undisturbed sleep. That absolutely killed me. And eventually it was one of the, alongside a few other things where I had my suspicions, it was like the straw that broke the camel's back, where I said to my wife, there's something not right in terms of what's going on, and I verified my ochratoxin level was sky high when I done the urine test, and that was about 5 or 6 years ago.
Yeah, well, if you feel like any of the medications that we spoke about today may benefit you, such as BPC 157, GH secretagogues such as Tesamorelin, IGF1, Oxidative, troche, Semaglutide, then you can obtain these from Transcend HRT, and the link for that will be in the bio. If you feel like you're experiencing symptoms of low testosterone, such as depression, anxiety, lack of motivation, as well as lack of sex drive, then you can get this checked out as well by getting your blood work done at Transcend, and they will provide you expert medical analysis. Transcend HRT has worked with many professional bodybuilders and pro athletes such as Thor Bjornsson, Phil Heath, and Jeremy Buendia. And if you feel like this podcast has any relevancy to you, I do believe that this clinic will provide of great benefit to you as well. Makes me feel a little bit better because I guess whenever I do go up to pee, the bladder's not full. So it's probably a little bit more of the other issues that you were talking about, such as just like, if it's not psychological, then maybe a sort of apnea where I am kind of waking up anyways.
Yeah, I mean,
once I'm awake.
That's something to see what happens with the mouthpiece. See what change. Yeah. I mean, like I said, you hit the jackpot. You sleep all night and you wake up and go, whoo, the full night's sleep without waking up to use the bathroom.
Yeah, for real. Cool. So, what about last thing regarding sleep? Because I know we were talking about a lot. We love sleep. Overheating in the middle of the night. So I know there's a lot of solutions these days. There's a lot of new mattresses that are coming out about like, oh, we have cooling features and all these things. You know, some people will just try to turn the AC down, even though there are those issues. There are those couples where it's like one couple wants it hot, one couple wants it cold. So then you got to figure out how to split that up.
Yeah.
But yeah, I guess, do you have any recommendations for that?
So when we look at like thermoregulation, how you sense the environment's temperature, one of the things, and I mean, we're going to bring up everyone's favorite molecule, tren. When we look at like tren sweats, or when guys have thermoregulation problems from tren, on the surface of our skin, these thermoreceptors on our skin are trying to tell us, well, is the body at risk of overheating? Does it need to perspire? Does it need to sweat to cool the body down? Is the internal core temperature gone too high? that looking at what estradiol and progesterone and progestins can have in enhancing the sensitivity of these receptors, you then start to see why women, even more so when you have estrogen problems, have sweating issues as well in their sleep. When we look at like menopause, perimenopause.
Yeah. Estrogen comes really low.
Like if we look at how to try and correct that, yeah, of course you can try and regulate the temperature of your mattress. Something as simple as the duvet tog, are you using the appropriate, do you have a winter time and a summertime tog? I'm not too sure on how things change in the US, but to put it in perspective, like at the moment in Ireland, we have like 22 degrees heat, which is extremely hot for us. And then you've got winters where it's like -4 outside.
Jeez.
That the house temperature, like I'm in my office now at the moment, and at 10 o'clock at night, it's 24 degrees in my office with no temperature on, although there's no windows open. If we're looking at the optimal temperature for sleep, being reported around like 17, 18 degrees Celsius. I'm not good with
That's
US.
below, I'm pretty sure that's below 68 degrees Fahrenheit, right?
But I wouldn't
like
know off the top of my head. Again, I'm horrible with Celsius to Fahrenheit. But for us, I guess real quickly, let's see, degrees.
I think 68 is 20, 86 is 30, 105, 104 is 40.
So at the moment, 24 would be 75, and then like -4 would be 24. So like when you look at the overall, I guess overall impact that environmental temperature is going to have and how your body's developed to those temperatures, normally our house sits at maybe 17 to 18 ambiently, like between the thermostat and running the heating. In the winter time, it's probably not uncommon for the house, if there's no heating on, to be 15, 16 degrees, which again is quite low. That if we're trying to optimize the room's environment between AC, where one person runs hot, one person runs cold, I don't think you're going to win the argument of where the AC should sit. And that might be down to then, well, what duvet cover is used in terms of like the thickness of the duvet. So here, again, with the UK, with such a variable temperature, and in Ireland, we'd swap between a winter duvet sheet and then a summer, so a lighter togged bed sheet, so that you're trying to offset some of the impact that the duvet's having on you when you're sleeping. One of the simplest things I've often said with guys, if they have issues with sweating at nighttime, is to sleep naked, which people laugh at. But if you sleep naked, your body has no hindrance from bedclothes and also maybe a bed sheet as opposed to a duvet, depending on, again, the heaviness of the duvet.
Right.
A cold shower prior to sleep, now not immediately before sleep, otherwise you'd be too stimulated from a norepinephrine release perspective. But if we can expose our body to cold with a cold shower maybe 2 hours before bed, might not be practical for someone, but if they can expose their body to cold, you're going to lower your core temperature prior to sleep, so that whilst you're sleeping, you've already set the pace for your body to adjust the temperature from a lower, colder exposure rather than the actual ambient temperature.
So I've always heard, you do a hot shower to lower your core temperature, are people trying to discuss like immediately before sleep? Is that why they say hot?
Yeah. So if you're doing it immediately before sleep, you do hot.
Okay.
And then if you do cold, I mean, this is coming from someone who's excessively sweating. If we're looking to optimize just normal sleep, then yeah, we do a hot shower, lower core temperature. Doing the sort of reverse and the cold exposure, the norepinephrine release, the shaking, the thermogenesis that comes from shaking, you're you're trying to almost get ahead of your body having to adjust its temperature set point when you go to sleep. So it's one of those ones, like you said, where you sort of look at it and go, well, a warm shower looks more appropriate from a core perspective. But if you're at risk of sweating and you can't correct your core temperature before getting into bed, where a hot shower actually has you feeling probably more warm than normal, depending on the environment of the room, your adjustment to that temperature is going to be offset. So the cold shower, sleeping naked, a bed sheet over a duvet, there's not much else than looking at the hormone perspective then of what could be enhancing that thermoreceptivity. Most definitely looking at a cooler material for your mattress, making sure that your mattress can breathe, to speak, so that there is air exchange from your bed. If you have the budget and you have two people that are fighting over the temperature of the room, then being able to climate control your mattress, although it's something I've never personally experienced. I can say that when I was younger, colder pillows were much preferred by me than a warmer pillow, or something more comforting about a colder pillow going to bed. That I can only assume a colder mattress is probably similar. That it's not freezing, but it's a little more inviting than a warmer one. The other things on top of that, there's nothing really supplementally that I could offer other than come to a compromise on your toggy or bed sheet, and look at potentially having that summertime versus wintertime bed sheet if your environment changes and you're not using AC. I guess we're lucky here that we don't have the problem that when it's too hot like it is here now, it's a temporary thing. So you just sort of deal with it. It's not like it's a consistent problem where you have to run AC to control the room's temperature. Quite often here, it's actually you need to run the heating to get the room to 18 or 19 degrees to be comfortable.
Yeah. DNP.
Internal, just uncouple your body's energy dynamics and let it heat itself up. I mean, even like excessive sweating in your sleep, it can be a sleep disturbance. Yeah. So we've all been there, myself included, where you wake up and literally your bed is just soaking and you can't figure out how that happened. Just I've always been fascinated to, like, if you had like a time-lapse video of what's happening in your sleep when something like that happens, like how much sweat has been released from your body to leave your bed sheets, like you've basically done 45 or 50 minutes of cardio, just as a consequence of your body sensing that it's too hot, so it needs to cool itself down with sweating. That there is nothing other than getting the habit of bed clothes might be appropriate, but they might not also be, depending on how you respond to the temperature of your room.
I'm glad we discussed this because I think many of us too who are on gear and PEDs are just freaking on fire all the time. So I think it's probably a common thing a lot of us encounter, regardless of whether or not we're on trend or not.
No, and I mean, even like your bedtime nutrition and your metabolic rate while you're sleeping, what you've eaten prior to going to bed, what digestive processes are going on. Like I touched on a very broad level of your skin's thermoreceptors and the environment. If obviously food creates energy, it's thermogenic.
Yeah.
That heat is released from your body. So again, if that heat builds up and you're underneath a heavy duvet, it's going to invariably create some level of like sauna, to speak, under the duvet that you are
That's
going
exactly
to start.
what happens to me, bro.
Yeah.
I love eating most of my calories towards the end of the day, so I know that's my problem. Well, one of my big problems.
And that can contribute, and that heat generation from burning the food, to speak, is creating the problem. So you've got, well, to put it in another perspective, sweating is a detox pathway. So you're just enhancing detox with sweat.
Let's go. Cool. All right. So I guess let's just wrap up the oxidative stress portion, so we can jump to the Q&A. But we covered sleep and then nutrition. You know, I'm assuming just the nutrition that most people know, right? Eat your fruits and vegetables, etc.
Supplements then, or even like peptides. I mean, this is a rabbit hole of what you want to do with your brain. Like I touched on, once the unfortunate thing and the reality is, once you kill a nerve or a neuron in your brain, that's it. Game over. It's not coming back to life. But what you can do is you can make the other neurons compensate for that nerve dying. So it's like having a ton of telephone lines or telephone wires, and you cut one of them. Now you've got less lines for transmission. I think I explained this in the last podcast, that what you do then is you do neural branching, where you're connecting all the phone lines together so that the speed of transmission is relatively the same as what it used to be with that neuron missing. The only problem is, obviously, neurons store neurotransmitters inside them, that when you kill a neuron, you're reducing your neurotransmitter level potentially of your brain long term. That just because we create these neural branches to speed up the transmission of the signal, it doesn't mean that you have the same capacity to carry as much information as you could before. So if, for example, if we look at a nerve that carries acetylcholine, and acetylcholine is involved in your memory formation, in, I guess, accruing new information. If you killed, or a neuron containing acetylcholine was to die, but now we are improving the transmission of the other guys of communicating with one another, creating more branches, the speed of how we send that information or recall that information is probably going to be improved, but our ability long term then to retain information from having a lower level of neurotransmitter is something that we wouldn't be able to correct. We could have obviously optimized our neurotransmitter creation from nutrition and supplements, but you're not going to make up for the fact that you're now down one neuron that could have stored X amount of neurotransmitter. So the most prevalent strategy of improving like brain health and overcoming that is increasing brain-derived neurotrophic factor, BDNF. And people have probably all heard this acronym. BDNF really, again, just stimulates nerves to branch with one another. So if we can improve the amount of neurotrophic factors within our brain, we're going to encourage these new connections between neurons and improve the speed of transmission. You've got various things, like coming back to like nutritional supplements, lion's mane, bacopa, relatively a lot of the adaptogenic herbs act as adaptogens by lowering oxidative stress. It doesn't necessarily mean that they improve neural branching or BDNF, but a lot of adaptogens will lower the impact that stress will have on our brain, and that in theory then will carry over to how the brain sends information as an overall. So adaptogens can be a useful thing to consider, but they're not strictly going to improve that neural branching. Stuff like lion's mane, probably at the very top hardcore wise that was investigated clinically was dihexa as an angiotensin 4 derived peptide, which was shown to increase BDNF levels in animals anyway by 7 times the control level, from what I remember from the study, which is huge.
I think but wasn't there like some discussion though of like the worry that it's so strong that it could increase brain tumor size?
Well, this is the thing, when you look at any sort of thing where we're improving, like BPC or TB500, we're improving angiogenesis. If we're improving blood flow through the body, you could influence tumor size. So there is most definitely a cancer risk with the angiotensin 4 aspect of dihexa. again, it's not been fully tested in humans to speak. So if it's something that you choose to experiment with, you have to be fully aware of these consequences. And that goes for something as serious as dihexa, or something as benign like we touched on with a B complex. So we can use something like that in theory that is available to perhaps influence BDNF in a very large manner. You have other things like Adamax or Semax, which improve BDNF expression in the brain as well, which more so probably from a nasal application perspective is more appropriate than an injectable due to that blood-brain barrier. So when you use something intranasally, depending on the molecular size and the carrier, in theory, you should be able to cross over the blood-brain barrier.
I'm actually currently microdosing that several times per week, maybe like 4 or 5 times per week. I mean, would you consider that reasonable and reasonably safe to just microdose for a small increase in BDNF?
Again, coming back to, if we increase BDNF expression without any negativity, what would be the worst case scenario to happen to our brain? And looking at like the very top level, I couldn't see anything hugely negative that would result from improving neural connectivity, other than being able to recall information a lot more readily, or carry an emotion. Another thing, carry neurotransmitters that influence our emotions a lot quicker as well. When we look at improving cognitive health, you have like 2 aspects. You either want to look at improving like your memory or your information retention, or you want to improve like your speed of delivery or your speed of critical thinking to make decisions faster. And both of them rely on that neural diversity of branching out to other neurons to either recall information really quickly or be able to deliver or recall and deliver that information as quick as possible. So you'd have someone who potentially could be thinking of something and then they're waiting for that like information to come to the front of their brain, and then there's a delay in how they're able to communicate that out. You'll find with improving BDNF and neural plasticity that your verbal fluency, how you're able to get words out, is a lot better. And you'll find that guys who do these sort of practices of influencing their brain chemistry see this change in terms of how they communicate, how they're able to have quicker conversations, or they're able to say what they mean in a more timely fashion, to speak. And sometimes people might I'll go on big tangents, but you're trying to convey what is being thought about in your head a lot quicker. So using dihexa, Adamax, Semax, again, there's nothing in my view that there's like this strict protocol, because there really isn't. We know what they do from a mechanistic perspective, but it's not until you actually start subjectively trialing things for yourself on what you feel from that experience or from that exposure to that chemical of your brain, that someone might see a huge benefit from a microdose of Adamax or Semax, and the other person might not see anything. Does that mean that it didn't work? Very hard to say. I mean, what's the expectation they're having on that BDNF increase without objectively measuring that BDNF number? You might perceive that being able to remember something you've learned immediately as being valuable. The other person might not necessarily see that increase of a scale with the use of that peptide, and so their perception of how it should be working on their brain is a little more grander, to speak. And so it comes back to what you subjectively feel when you do these increases.
Gotcha. Okay. Yeah, I feel like we can talk about oxidative stress for honestly an entire day. I guess if I were to wrap this up, because I want to be sure, I want to be able to go to the Q&A because there's a lot of questions in there, and I'm going to be real. I actually was thinking before the podcast started, like, oh, it'd be great to go to the Q&A halfway through, and
you go on
of course,
big tangent.
I always have so much to talk about whenever I talk with you, which I freaking love. So, I mean, that's my favorite part about it. But oxidative stress, I guess, if we want to wrap this up, like I know there's a lot of other supplements and that we can go into, I guess, man.
It's a wormhole. And I mean, that's where, as someone who like formulates supplements, I am always going to be the first person that's very blunt in, well, what is the dietary need for using these supplements, or what is the environmental need for using these supplements? For example, like if someone is extremely stressed mentally, that cortisol is going to have an impact on their sleep, and it's going to obviously, going all back to what we've conversed about there a moment ago. If they were to take something like an adaptogen to lower the response to stress, they're going to see better sleep, they're going to see better mood, they're going to see better work performance, everything else snowballed. Mm-hmm. Does that mean everyone should take an adaptogen? No. And then does that mean that you would recommend an adaptogen as the first thing for a stressed worker to take? No. So it's always really interesting when someone asks, what's your top recommendations of these supplements? And then when you turn around and say, well, I have no recommendations because X, Y, and Z context, they're almost shocked because they're expecting you to have some sort of sales pitch on, well, if you take this, you're going to be so, super optimized in terms of like family, work, career, sports, whatever. Mm-hmm. And it's just not the case. And that was always a vital part of like my integrity of the sort of supplement business, that you ask someone what they need to take, the answer back from me is, well, it depends, and it's a long, long list of depends.
Mm-hmm. Gotcha. Okay. I say if you're down for it again, if you're ever up for coming on again for a third time, then we can like expand a little bit more on ancillaries and reducing oxidative stress through supplements and even maybe medications if there are potential possibilities there. But I know in the Q&A, some people actually ask some specific questions regarding things like medications and supplements. So I think that would be a little bit more effective right now. Yeah, so let's just move on to those. There's one more thing that I was going to say before we move on, but I completely forgot because I brain farted again. Per usual. Whatever. Well, if anyone else, though, in the audience is interested in delving a little bit deeper on, I guess, neuroprotective methods and maybe peptides and stuff, I had this podcast with Biohacking You, Brandon, who has done a lot of pretty extensive research on peptide use and neuroprotective methods. So we discuss things also just like choline up regulation for memory and some other various things that I think could be effective.
Yeah, Brandon's a good guy. I've spoken with him a few times and he's well tuned in. So it's definitely something I'd recommend people to listen to. I was actually listening to it earlier. So it's nice to see, all this information going out there to the right audience that, in my view, are in critical need of having easy accessibility to stuff that isn't talked about mainstream or won't be spoken with their healthcare practitioner, or just stimulates thoughts that you can bring these questions to their healthcare practitioner of concerns they might have. And then they know sort of, it's almost cheating because they know where they want the conversation to be guided if they are seeking medicative help, because they're aware of what medications are available, how their mechanism of action works, what potentially they're doing with their nutrition, etc., that you might need this support from the healthcare practitioner.
Awesome. Yeah, I really like what you said earlier too regarding because it was literally it aligned with the thoughts that I had as well about how just, you know, a lot of us, especially in the bodybuilding industry, for example, will focus so much on organ health, but then, you know, people aren't getting these regular scans of their brain every 2 years or so. You know, most people kind of just disregard what happens to the brain. So until like we're, you know, later on in life where we're like realizing we're forgetting more things and et cetera, and then it's a little bit panic occurs. So I think it's really cool that there are a lot of people like you guys that are discussing this openly now.
I mean, as much as we all fear as bodybuilders, like having a sudden like cardiac event, the other thing, you know, that makes you realize you're like the master of your own destiny is you don't want to be in like your 60s and 70s and being, not to be strict speaking, but to be a burden on someone because of your mental health, of not being able to remember things. And obviously then your life experience is completely impacted because it's something that is very difficult to fix. And fix is putting it lightly because, like we covered, once a neuron is dead, it's done. You're trying to optimize the brain's compensation of that dysfunction that me personally do. Genetics aside, I'll do everything to try and ensure that brain health stays at the forefront, forgetting where I put my keys aside.
Are there any neuroprotective things or ways or supplements that you recommend people do to, I guess, avoid their neurons from dying?
It's, you know, when you look at what triggers nerves to die aside from excessive neurotransmitter, like excessive dopamine. We're all aware of like dopamine. Glutamate transmission, when we have too much glutamate in our brain. Glutamate is an excitatory neurotransmitter, and it's a relative of GABA. Glutamate will, in theory, poison our neurons. Now, are there things that we can do to help with glutamate metabolism? Most definitely. Can we look at the foods we eat and potentially what can be broken down into glutamate in our body as well from the food we ingest? Absolutely. But I would not say there's something that you take it and it's an insurance policy that your brain health is going to be protected, that you take this compound and nothing will ever happen to your brain. That, again, it comes back to like the very basic things are the antioxidants. If you've got good glutathione, good vitamin E/vitamin C, CoQ10, you've got the building blocks of what are really going around your body doing a lot of the internal protection, controlling your iron, controlling your glucose, controlling your exposure to electromagnetic radiation. You know, we all discount that because we can't feel it.
Yep. I always get scared because I always carry my phone right next to my balls. Pocket.
Like, but in that, you know, I've spoken about, we went on honeymoon to New York and Times Square, and I remember opening my phone. I was like, there must have been at least 300 Wi-Fi hotspots around me. It was insane. And you're in this small enclosed area with tons of electromagnetic radiation around you that you can't feel, but your cells most definitely are feeling it. But you're using melatonin, glutathione, and all your antioxidant cascades to keep that damage that's trying to come into your body, that energy coming into your body, at bay. That something as simple as that you don't think about. You don't think about where you travel to. You don't think about the impact that flying in a plane has to your oxidative stress. You know, things that we take for granted. Driving on a motorway with pollution, you know, if you're stuck on a motorway with an accident, one of the things that you could consider doing is having the air recirculate through your car so that you're not pulling all the exhausts of the cars that are stopped in front of you through your car's air itself, so you're not exposing yourself to all the toxins in the air while you're stuck in a traffic jam. Simple things surrounding that impact on your antioxidants and your oxidative stress, without even thinking about like what you're taking is doing to your body. So it definitely makes you think of the broader thing, that there's no one singular supplement or food or strategy you can do to offset this effect on your brain. It's like what is readily available to you from a nutrition perspective. What are these core basics we talked about, antioxidants? What can I maybe do with EMF, whether that is like EMF shields, as woo-woo as it can be, grounding,
I'm glad you said that, as woo-woo as it could be, because I got a couple of those little black metals that you can put on a necklace that I used to buy my laptops and shit.
I have one here on my phone. I've got, I forget the name of the company now, but it's sitting on my phone here on the desk. So I mean, anything little like that, I'm talking to you now, and as much as I get comments about banging on my table and making noise, my hand is on top of a grounding mat at my desk. So I've got a grounding mat where my keyboard's on top of the grounding mat. Again, as crazy as it is, I'm just thinking consistently of what are little things that I can do that maybe in the grand scheme of things will offset a small amount of oxidative stress. And in terms of like long-term health, it's like compound interest. You're doing these small little things in hope of when you get to like, I don't know, let me throw a number, say 70 years of age, and from a cellular perspective, you've managed to maintain a lot of your youth, to speak. And it's because you've managed to slow the rate of aging from keeping your cells functional, from reducing oxidative stress. That these silly things that might seem benign have played up into the bigger equation of things of keeping oxidative stress under control. And that, whilst it's all the rage, it's good to see that in the last 2 years, like, research is bringing a lot of disease back to oxidative stress and mitochondrial dysfunction, where we're going into the nitty gritty of why did this problem happen? And we're starting to really zone in on, well, the mitochondria became dysfunctional, and then everything played off that, whether it's cancer progression, cellular dysfunction, glucose problems, iron dysfunction. I'd say probably by the time I'm 60, so like another 22, 23 years, that we'll look back like on the conversations we're having now about oxidative stress and mitochondria, and we'll be almost looking back at how we view early 1900 medicine of, they laughed at, the guy who proposed washing their hands prior to surgery because there's bacteria in their hands, being sort of ridiculed by doctors, going, you don't wash your hands, don't worry about that. That we look back and say, when we viewed problems occurring in the human body as compartmental problems, so diabetes being a problem with glucose management, where it's the pancreas, where it's the liver, where it's the insulin receptors on your cells, we'll start looking back potentially at saying, well, what happened in the beginning was the mitochondria just couldn't facilitate the glucose from being utilized correctly, and it all fed upstream, where the final thing that really took it was insulin sensitivity or lack of insulin production, etc. That I think we're on an exciting time where people are starting to really shift their analysis into what are the key guys in our biology that are keeping us alive and driving a lot of the problems that we encounter day to day. And, we look at how we appear visually in terms of age now. We've got 40-year-olds today who, for better word of putting it, they look maybe in their 20s. If you compare that 40-year-old of today back to a 40-year-old in the 1940s or 50s, where again, there wasn't much attention or lack of awareness to oxidative stress. There was a lot of mental stress from the environment and whatever else we want to consider back then, economy, everything else, lack of technology. As we progress through time, again, with that whole like human evolution, we'll start to see, well, if we can intervene at a very young age on oxidative stress, and I guess this is an important thing to touch on before we get into Q&A, is, without going on a tangent, oxidative stress is important to our body. So oxidative stress, when we look at like what induces hypertrophy, it is a stress to the body. So there is going to be reactive oxygen species made to create a stressor on the body to overcome that stressor. If we are chronically hammering our body with antioxidants and keeping oxidative stress like completely diminished, then that's going to set problems, because of we're going to interfere with our adaptation process of our body, where we have to create these reactive oxygen species to see a knock-on effect within the body. So that's an important thing, that if we're constantly hammering at glutathione injections, IVs, it's important to sort of understand how is that glutathione playing into the grander scheme of things, because we do want to have a small level of oxidative stress for how our body operates. It's just not good for having excessive oxidative stress, where chronically you have low antioxidants. I
guess that's why it's pretty smart to be aware of like I guess timing when it comes to reducing oxidative stress, though. Like I guess say doing like glutathione shots or IVs on like rest days particularly, or rested periods of time. I know one of the things that I also use as an example, like arachidonic acid, only timing those, using those on specific days where I'm like, oh, this muscle group I feel like is the most important for me to grow, like leg days, in order to increase the inflammation on those days.
I mean, even like cold exposure, where you should really avoid cold exposure within 48 hours of resistance training, because you're interfering with the inflammatory process. And I mean, creating oxidants in our body, I guess saying having a level of oxidative stress is probably not the best way to describe it, because oxidative stress would mean you don't have enough antioxidants. Oxidation and oxidants is probably the best way of saying it. We need a certain level of them in our body for these processes. And if we're constantly mopping these oxidants up before they have a knock-on effect to create the change we're looking for, that can be a problem, rather than having a small amount of oxidative stress.
Okay, gotcha. That makes sense.
So any level of oxidative stress is probably a bad thing, because it means that you've got a lack of antioxidants. I should clarify that before anyone comments down below what I've said is incorrect. We want a level of oxidants. We most definitely want to keep oxidative stress under control. So yeah, think about that before you start piling all these antioxidants in again as supplements, that I'm going to hook myself up to an IV of glutathione, NAD, vitamin C, just give me as much as I can take. It's probably going to have negative consequences than positive benefits.
Awesome. Cool. Let's move to the Q&A. Sorry about that. It's probably my train coming in.
Answer if you have to answer the front door, go.
Oh no, I'm sure it's probably just like an Amazon package. I was just joking around. Cool. All right. So many. Everybody loves you, Dr. Dean.
I greatly appreciate the love. It makes doing these things worthwhile.
Elijah Sigur asks, is the rate of lean tissue gain the same on Mastron as comparable compounds?
So there is a cellular paper. There's a paper with Hirschberg assays which are done on rats, and you look at the rate of tissue growth in basically the levator ani muscle versus the seminal vesicles of the rat. So you look at the androgenic to anabolic ratio of the drugs with Hirschberger's. This paper basically shows that all steroids roughly caused the same rate of development of tissue when you looked at the drugs that were used. So to note, there was Anavar, Winstrol, Nandrolone. Mastron was not on it. But the consensus from that paper was that all drugs build muscle at the same rate. When you look at, in theory, that may be true, but then you look at the broader picture, and to give credit, Dr. Scott Stevenson has a brilliant presentation of this with Scott McNally about this sort of question of, does Mastron build the same amount of tissue as Primobolan? If you were to just take strictly Mastron or strictly Primobolan and compare them to one another, again, looking at rates of genetic clearance, how everyone expresses the androgen receptor, the CAG repeats, everything else with that, a broad assumption would be, in theory, possibly that they all build muscle at the same rate. But in practicality, people are taking 2 or 3 different steroids at one time, that you can't say that if I swap Mastron in, it's going to build the same amount of tissue as if I took Primobolan, because it's a very broad assumption from a distinct assay in an animal. Simplistically, in theory, you could say yes, but in the grand scheme of things, probably not. And this is again where this whole argument stems from: Mastron not being an anabolic versus Primobolan. Mastron, people will argue, can't build muscle tissue. When we look at Mastron's molecular structure versus Primobolan, it's very similar, aside from a substitute that's been made on the A ring, and then the other one has a double bond. Aside from that, they're relatively similar structure-wise, but then when you look at the molecular weight of the compound is slightly different. And this is what I try and get people to think about, that when you take a medicine or a drug or an anabolic, whatever way you want to phrase it, whatever milligram you take of that compound, you're not taking it for the milligram. You're taking it for how many molecules of that drug are in that milligram dose. And we're talking billions, quadrillions, trillions. It's a huge number in that small dose. That when we compare different steroids and their molecular weights, they vary quite differently. So if you look at Nandrolone, you've removed that 19 methyl group, the CH3. That changes the molecular weight of the compound versus testosterone. So now you have a compound that has, in theory, a lower molecular weight than testosterone. So if you have 100 milligrams of Nandrolone and 100 milligrams of testosterone, there's a lot more molecules in 100 milligrams of Nandrolone than there is in 100 milligrams of testosterone, because of the molecular weight difference. So you couldn't ever say, if I take 100 milligrams of Nandrolone and I take 100 milligrams of testosterone, that they're the same, because the number of molecules is completely different between the two. And that's where, in theory, you start to see Nandrolone, Trenbolone being potentially stronger drugs because they have lower molecular weights, which means there's more molecules in that dose. And more molecules means more interactions with the receptors. So when we're looking at compounds and milligram dosages, in reality, it should be, well, how many molecules are in that set dose? And this is something I spoke about years ago. I know Steve done a video on it before about, like, look at exactly how many molecules are in that compound based on your dosage. And then you can't really strictly compare apples and oranges. you can make a broad assumption that, okay, on paper, it looks like most steroids will have nitrogen retention at the same rate as another one. But then you have to consider that is just in a simple system, not in humans where you have, I guess, liver metabolism, kidney excretion, other things that impact steroid hormones binding. That it sounds great as a discussion point, and sometimes it can be an easy way to try and explain to someone when they're like, what steroid do I choose? And you're like, well, in theory, they all build muscle the same way. Practically, when you start stacking steroids, and this was the whole beauty of Scott's talk, is that this polypharmacy makes it so murky that you can't say that because I added in this compound, it's building more muscle than primobolan, or it's building more muscle than nandrolone. So it's very hard to give a direct answer that Mastron's going to build the same amount of muscle as any other steroid. But it's always a great discussion point.
Mm-hmm. You don't happen to remember his comparison of like the amount of molecules of like tren versus like EQ versus primo, for example?
So I have a post that I done. I can send it to you if you want to overlay it here, which showed the number of molecules between testosterone, nandrolone, I think tren, mastron, and primobolan, and why, when we sort of look at primobolan, to make like a very abstract statement, where primobolan is a relatively harmless compound, whereas like it's not as strong as the other guys, to speak, if you want to put it that way, that like conversation terms, 100 milligrams of primo versus 100 milligrams of testosterone, there's millions upon millions less molecules in 100 milligrams of primo versus 100 milligrams of testosterone. So when you take 100 milligrams of primobolan, you're exposing your body to a lower amount of androgens versus 100 milligrams of testosterone. Mm-hmm. It has different metabolic pathways to testosterone. So it can be the tree position of the steroid can be reduced. So it has that tree keto position reduction that might not necessarily happen with testosterone. And so when you look at primobolan being a quote unquote safer compound, on a milligram basis has a less number of molecules than testosterone, and it has a higher potential rate of metabolism within our muscle tissue before it even affects an androgen receptor. So when we're looking at, when we're trying to assess building a stack, you never really think that, well, 100 milligrams of primo has less molecules than testosterone. It's just like it's 100 milligrams versus 100 milligrams.
Yeah. And
really, the 100 milligrams of primo is way lower in molecular number than 100 milligrams of testosterone. And conversely, you put 100 milligrams of nandrolone in, has more molecules than the other two. So you can see then you're not, if you're really like pedantic or you're really nerdy, you could probably work out like the molecular number on, you know, the milligram level and how they're all balanced molecularly. Then from that perspective, if you put in, it could work out as abstract of, to make an example, like 134 milligrams of primobolan to 96 milligrams of testosterone. No one's going to do that. It's going to be too difficult to measure it out. Mm-hmm. And it just creates too many layers of complexity that most people won't have the patience to work out. You know, even myself included, I've never sat down and thought, I'm going to build a cycle based on the number of molecules. Mm-hmm. But you have to think that way when you take these compounds. That's what you're exposing your body to, is chemical molecules that are going off to interact with receptors. Mm-hmm. And inside that 100 milligrams is a defined number of molecules.
Gotcha. Cool. Sorry, it was perfect timing that just as you were saying that, the story expired. Definitely intrigued to see that, and I feel like people should definitely watch Steve's video, whatever the video is titled. I feel like that would be super neat. I feel like I would expect trend to just be in the billions.
It's a great talk.
All right, found it. Danny Bryan 07 asks ancillaries for HDL and LDL control if ezetimibe isn't doing enough.
Great question. I guess we're going to come back to our best friend again with oxidative stress. When we're looking at cardiovascular disease protection or prevention, ancillary wise, we have to view that when we take androgens, we're going to produce more hepatic lipase, which is the thing that breaks down HDL. So it is a losing battle to do anything to try and improve your HDL level if we're already suppressing its production or we're breaking it down very quickly. What your strategy should rely on is improving the HDL's function or its receptor function to work better. HDL, really the only thing that has shown good promise aside from like basics like doing your cardiovascular activity to help raise HDL production. To be honest, again, if you have high levels of testosterone or androgens, you're going to create hepatic lipase, which again is just destroying the HDL that your cardio is trying to create. That your strategy really should be around how can I improve protecting my LDL from being oxidized, and what can I do to reduce the expression of apolipoprotein B, which is the protein on your LDL that basically tells the LDL to dump its cholesterol into a cell. So when you take something like a statin blocks cholesterol from being manufactured, and as a consequence, you block ApoB from being created. ApoB would be on your LDL particles. So the statin is really trying to reduce your ApoB expression or your ApoB level than directly going to LDL as the root cause.
But there's a particular reason why the statins are normally having a very low success rate, right? Like you're basically just delaying.
And this is it. And this is because when you look at what drives atherosclerotic plaque production, ApoB is one of the things. The ApoB receptor, you bind the ApoB and the LDL dumps its cholesterol off. And if that happens to be an artery inside the arterial wall, and that in turn then leads to plaque accumulation alongside what we consider an immune dysfunction, in that when our LDL becomes oxidized, so if an oxidant like a free radical damages your LDL in your bloodstream, and it's just doing its job of carrying fat, it's just a bystander. When your LDL gets oxidized, it's now unstable. So free radicals basically steal an electron off a substance. And now you've basically created best way to describe it, like a wibbly wobbly LDL particle who's going to try and look to stabilize itself by taking an electron from someone else. So it becomes like, who can I rob an electron from to stabilize me? If that LDL can't stabilize itself by taking an electron from somewhere else, and this is where vitamin E comes in. Vitamin E is the guy that comes along and offloads an electron to the oxidized LDL and goes, I've got you, here's your electron, you're now stable. And vitamin E takes an electron from vitamin C. That's how vitamin E is protecting your LDL from being oxidized. But if the LDL gets oxidized and you don't have enough vitamin E to protect it, your immune system, your macrophages, the little Pac-Man, come in and eat up that oxidized LDL because it realizes if that's in the bloodstream, it can damage the arterial wall. It could take an electron off the arterial wall, it could take an electron off a nearby LDL particle and just set off a cascade of one to the next being oxidized. What ends up happening is you create a foam cell whereby the macrophage, little Pac-Man, eats the cholesterol, and now it's sort of sacrificed itself where it itself has become very, very sticky. But these foam cells know that if they stay in the bloodstream, they're going to cause their own level of dysfunction. So they leave the bloodstream into the arterial wall space. And slowly over time, these foam cells aggregate and stick together and clump together with bits of calcium to form arteriosclerotic plaque.
Right.
And then that presses in on your artery, creating a bulge. And then that bulge forms a huge amount of pressure. So if you imagine your arterial wall is getting smaller and smaller, these bulges are building in. And then they rupture. And then that big massive mess of foam cells and calcium is in your bloodstream. Your immune system, more so your platelets, see this big massive dysfunction, and they clot around it to try and protect the body. And that's the clot that forms with like a thrombotic clot that goes to your heart or goes to your brain for a heart attack or a stroke. So if we're looking at offsetting arterial plaque formation and ancillaries for this, ezetimibe is more so working locally in the gut. So you have, to not get into all the boring science of it, you produce cholesterol in your liver. Most of it goes to your gut, and then most of it from your gut is reabsorbed into systemic circulation to bring fats to your cells. And then HDL brings the fats from your cells back to your liver for recycling out, like excreting out in your colon. When you take ezetimibe, you're trying to block some of that cholesterol reabsorption so that you basically poo out your cholesterol. You have other types of medications that bind that cholesterol into your feces and you poo out the cholesterol. So you have bile acid sequestrants. Very like old school medicines where they approached dietary cholesterol as being one of the root causes of heart disease. And if we can pull cholesterol out of the gut, we're going to protect the body, which is useful, but ezetimibe isn't going to come at the angle of if you're making ApoB protein on your LDL cholesterols, you're hoping that some of those guys are being pulled out from the gut with the ezetimibe, then going into circulation. What we should look at if you are at high risk of ApoB expression with high LDL is potentially looking at a statin. And as crazy as it is when people argue about statin use and what risks come with them, there are most definitely risks with their usage. But if we can selectively maybe utilize these statins in an appropriate way to lower that cholesterol's production, so you're lowering the ApoB, as a long-term strategy alongside managing oxidative stress, you're blocking the LDL and the ApoB. And how we tie this together with that sort of failure rate is most people who take a statin just take the statin and never focus on the oxidative stress and the damaging of the LDL. So to put it in perspective, let's say you have a cholesterol level in US terms of 200 or 210, like a really high number. And in theory, a statin lowers cholesterol production by about 50%. That's what they roughly estimate it at, is about 50%. Most statins have efficacy at blocking the key enzyme that creates cholesterol. But let's say that 210 level of LDL cholesterol is being oxidized 100%. And if that continues without a statin, your primary risk of having a heart attack, let's say it's 2.5 years. Taking that number from 210 down to 100, so let's just have, or 105, whatever way you want to put it, but you're still oxidizing 100% of it, you're still generating plaque from that oxidized cholesterol, but at half the rate, at slower the rate. So really you've bought yourself maybe another 2.5 years. So whilst you're heading for a heart attack in 2.5 years, you probably have a heart attack in 5. And that's where you see a lot of statins still attribute themselves. I mean, the success rate of a statin primary risk prevention, with stopping someone from having a heart attack, absolute risk reduction is about 3%, which then tells you the bigger picture is lowering the cholesterol number plays a part, most definitely, but how that cholesterol is being managed in the bloodstream, whether that is oxidative stress or a lack of antioxidants, is probably more important to consider, and the influence then that our antioxidant control has on atherosclerotic plaque formation. You have other medications to consider with heart disease risk that are becoming quite popular, although it is very specialized in how they can be prescribed, and they are the PCSK9 inhibitors. With blood work, again, most people look at LDL. They can look at ApoB and they can check their ox-LDL. They're the main things, and what I love about the US is it's relatively easy to get an NMR particle analysis to see whether you have large or small LDL particles, which is another context to take into consideration. Because if we have very small, dense LDL particles, being the majority of the LDL fraction, they're relatively small enough to pass between the cells of the arterial wall to deposit themselves. That when we look at PCSK9 inhibitors, we're basically blocking one of the core receptors in the liver that tells cholesterol to be made, to put it in a very simple way. And this is also a way of controlling lipoprotein A. Most people will probably have low genetic susceptibility to LPA, but those who have high LPA, there's very little that can be done to address it. And whilst there's a paradox that if you take a lot of steroids, your LPA level will fall, that's a very poor assumption, because in the paper that seeing this drop in LPA level from a high level of steroids, the LPA level was still very, very high. So to say taking more steroids will lower your LPA marginally, but it's still going to be out of range. It's not a strategy to fall for. That PCSK9 inhibitors alongside some form of statin or some way of controlling cholesterol production can lower LPA from being made. So again, if guys are doing blood work, listening to this, check your LDL, check your HDL, check your ApoA. So this is the protein on your HDL that helps it do its job. And that's where we should target our support on HDL, is making what HDL we have functional. So again, protecting HDL from being oxidized. And that's where strategies like citrus bergamot, all these flavonoids and polyphenols play into it, because they help protect dysfunction against your HDL. They do have a benefit in a certain capacity to stimulate your HDL from being produced, but it's madness to think that if you're on a super physiological cycle and you're taking 2,000 milligrams of citrus bergamot, that your HDL is going to be above 40 or above 1 in UK measurements due to taking a supplement. You're not going to circumvent the biology of what the androgen is doing by destroying your HDL. And that lowering of HDL is where the consequence falls, where your liver tries to compensate by making more LDL. So when you have a drop in HDL to try and maintain the balance of the lipoproteins, you'll often see HDL go down by 10% and LDL go up by 10%.
Gotcha.
And that's sort of where your strategies rely on antioxidants to offset the oxidative stress. You can do stuff like ezetimibe or fiber, increase your fiber intake like psyllium husk, apple fiber, stuff that will bind dietary cholesterol in your gut to try and excrete some of it out alongside what you make endogenously. If there is a needs basis there for a statin with familial cholesterol risk or high ApoB, don't discount what that could do for your long-term cardiovascular disease risk prevention. But bear in mind that it's not going to have a successful or guaranteed outcome 100% of the time. If we look at that 3%, there's other things that have to be paid attention to, that this is just something to be in your arsenal that you're not afraid to consider, because there can be, again, a bit of hesitancy when it comes to using medications like this, which is completely warranted because you see effects to CoQ10, to the mitochondria. Like statins can be mitochondrial toxic, that you could be creating a whole host of problems. Again, you need LDL to transport fats through your body. Your brain is no different. You need LDL to transport fats to your brain. If your LDL value is extremely low, you're not able to facilitate fat transport to your brain. So there's a healthy balance that if you do use them, like an AI, you don't want to bury your cholesterol to basically nothing and champion it. You need a small amount of it to help with your biology.
Gotcha. Okay. So I guess you just using me as an example, because I think I feel like I land a little bit more with a higher percentage of the population, but someone like me who, when you're running gear, has a lower LP little a or a low LP little a, but then has obviously high LDL from the gear that you're running, and then also a high ApoB. In my units, in the blood work that I get from LabCorp here in America, they recommend lower than a level of 90. However, I've had some personal conversations with Derek, More Plates, More Dates. Obviously, he likes to err on the side of extreme caution. So his ApoB levels recommended were really surprisingly low. I can't remember what he said. I think for bodybuilders, just something around like 40 or something he'd recommend, or 50. But and then he said, like, he had a conversation with Peter Attia, if you want to be super extreme and be like, oh, I want zero risk of cardiovascular disease or whatever in the future, to aim for like 25, which is I feel like going to be like impossible for most bodybuilders, honestly.
In theory, it most probably would be, given that if a statin intervention is giving you a 50% reduction, at most maybe 60% decrease in LDL production, as a standalone therapy, obviously add PCSK9 on top of it, that will lower a few more percent. You add in ezetimibe from a gut perspective, another few percent. It's not impossible, but given that we're dealing generally with LDL values that are, quite high, above 150 anyway in US terms, or above 3.3 in UK terms, an ApoB value of like 25 is going to take a lot of diligence to get down to that level. But in saying that, you're looking at like zero mortality risk of ApoB contributing to your plaque formation, which still allows a small amount of your LDL to be oxidized if you're not paying attention to the other thing of oxidative stress, which I'm sure if you're going to all that trouble to completely diminish the risk from ApoB and LDL, that you would be doing strategies to offset the oxidation of it. It would be just a bit ironic to pay attention to all these strategies, put your ApoB to 25, but the LDL is still, although it's a low number, is still being oxidized and then triggering foam cells to be produced that might take years upon years for plaque to form. But the irony would be, maybe if you went and then done an MRI and you found that there's soft plaque in your heart from doing all these strategies, and it was because you didn't pay attention to one of the pillars, with it being the oxidative stress. I guess if someone is worried and they're approaching like their 30s, not to throw like age numbers, but they're approaching their 30s having done bodybuilding in their 20s. When you sort of reach your 30s with bodybuilding, from my own personal experience with, like, I never had aspirations of being a pro, so I can't say when I got to 30, I was like, oh, it's now or never. I've got 10 years to try and get into the pro league, and then I've got maybe another 10 years till I'm 50 to be a decent pro. Mm-hmm. When you get to that age, bodybuilding is probably still an integral part of your life if it grew with you during your 20s. But now you're starting to think about getting married and having kids and career, corporation life, or whatever, your own business, that your focus on health shifts a little bit from your view in your 20s. If I do these supplements, I live this lifestyle, there's very little that can happen to me. Doing something like a CT angiogram with contrast, so doing a CT scan of your heart with contrast, will basically show up if there's any soft plaque, any calcification, or any, I guess, aggressive plaque that's formed in your heart. When we look at calcium scores look at long-term plaque that has calcified. And that tends to be plaque that has been in our body for at least 5 to 10 years. If you do a CT scan for a calcium score at like 30 and it comes back 0, that you've got no calcium, that you've got basically nothing's detectable, that's looking for just calcium for long-term plaque. Unless you really done a lot of very like negligent things during your 20s, the instance of having calcified plaque heading into your 30s, it's not uncommon, but if you are a very diligent bodybuilder with supplements and everything else, it's unlikely in my view. The other side of it is if you do it with contrast, you'll start to see small soft plaque developments where you start to see some of this plaque form, but not necessarily be an arteroma where there's an actual lesion with plaque forming inside it. That doing something like that then gives you like a 10-year risk analysis of, if you do the CT scan with contrast at age 30, it's saying roughly what you've done the last 10 years of bodybuilding has had minimal impact to your cardiovascular disease risk for the next 10 years, provided you continue doing what you're doing. That an echocardiogram, whilst everyone like champions this from a left ventricle hypertrophy perspective or septum thickness, it's very useful, it's non-invasive, it's trackable, you can compare, do an echocardiogram every 2 years. It's not a massive exposure to radiation. A CT angiogram with contrast, if someone is seriously thinking about going into their 30s on bodybuilding, having done it for a significant portion of their 20s and exposure to androgens and whatever else, doing that as like a sanity check of, okay, I'm going to really see what's gone on in my heart based on my blood work. And your blood work could have had skewed LDL and relatively lowered HDL for a number of years as a bodybuilder. And you do the CT angiogram and the contrast agent finds that there's nothing gone wrong with the heart. There's no plaque formed. Doesn't necessarily mean that skewed blood work is healthy. It just means that whatever you've done strategically in terms of the management of how that cholesterol is operating in your body has yielded a low risk. But it still gives you an idea of making a decision on whether or not I want to pursue bodybuilding for the next 5 years. Because someone might have a risk tolerance that if a small amount of plaque is found with that CT angiogram, even if it's soft plaque, that's the end of their career. I'm done with bodybuilding. It's not worth having a heart attack if I keep doing what I'm doing. Mm-hmm. It's a useful thing that guys should try and consider if they have access to, or they have worries about their blood work. Again, working with their primary care physician to maybe refer them for this sanity check. But again, going back to the difference with an echocardiogram, a CT scan is basically a massive X-ray. So there's consequences of being exposed to that radiation. Everything comes with risk. So it's not like I'm going to do a CT scan every year to keep on top of my heart health, because it would probably not be the most healthy thing unless there was a medical necessity for you to undertake that risk. Mm-hmm. But supplements, ancillaries, we sort of covered like the medication side of things, nutrition, look at polyphenols, look at antioxidants, simple things like turmeric, curcumin, CoQ10, grapeseed extract, astaxanthin. I mean, when I was looking at formulating our heart stack, I just basically looked at what were a lot of the key polyphenols and antioxidants that potentially could be useful to humans' nutrition, looked at potential dosages that could be considered, and basically put 15 ingredients into the one product to try and make sure that I was covering as many bases from a nutrition perspective that might be lacking. But again, just to close it, that with a supplement like Heart Stack, let's say your nutrition was very devoid of overall nutrition and very ultra processed and whatever else, thinking that taking a tub of Heart Stack per month and continuing to eat crap, basically, that the Heart Stack is protecting you from what you're ingesting, is a very bad way of thinking if we're looking at nutrition as being like the pillar of our health. Mm-hmm. That you're using the supplement to enhance your nutrition. That if you don't like having grapefruit, or you don't like having certain vegetables or fruits, you're using this as a supplement to get them into the diet, not as like I'm going to take Evenol, which is like all the forms of vitamin E, as a supplement to offset me eating burgers and pizzas all the time. That right. The supplements have to come into the equation of supporting the pillar, then being the insurance policy. I guess what I'd hate to think that someone's buying supplements thinking that I have to take this product because it protects me from X, Y, and Z. That can be a very slippery slope, both financially and psychologically.
Mm-hmm. Yeah. And I think, as I discussed with Austin Stout, like if it's an issue to have a certain amount of like vegetables or fruits, or even specific vegetables that maybe even irritate your gut, at that point, if you're still looking for a supplement, I mean, it's even beneficial for you to at least supplement with some greens there. Obviously, you should still try to make sure that you have you're meeting your daily intake of fiber, but worst case scenario, and you need a supplement with something, like you still need a supplement with the fruits and the vegetables in some sort of sense.
Absolutely.
Cool. Let's ask this one last one, and then there are so many questions, but I'll ask that afterwards, basically. But Henry Pham asks, is the mitochondria stack of SLU, MOTS-C, and methylene blue beneficial under 30 years old?
That's a very good question. I mean, I have inadvertently brought this trifecta to the bodybuilding industry that was a personal experiment. That's the way I always explain it, that what I put out is what I've personally done, and then people, if they want to trial it on their own research, that's their own discretion. Under 30, let's think about where we are in terms of our development, and let's say that this 30, well, let's say they're 25. Let's not even say they're near 30 where they're let's say they're 25. They have been following a healthy lifestyle. They've been following like some of the core basics that we all preach, with steady nutrition, sleep, training, everything else. Do I think that considering something like mitochondrial optimization should be at the top of their list? Probably not. Unless they had some signs of mitochondrial dysfunction. But the argument to that would be fix what's causing your mitochondrial to be dysfunctional than looking to optimize how they work in the body. And if we even keep this as a natural person, if we look at how we began the conversation with mitochondria, with hormone creation, neurotransmitter creation, at 25, would they have been exposed to so many things that would cause mass mitochondrial dysfunction? Probably not. Although, again, you have to look at the environment. Have they been exposed to toxins, pesticides, all these things that we wouldn't even consider that could be causing issues with their mitochondria or their gut health? In that instance, if we help support the creation of more mitochondria, but there is dysfunction happening from the environment, you're creating them for them to be effectively poisoned or to be harmed. And then they produce reactive oxygen species themselves, or their dysfunction knocks on to DNA repair, or the energy required to repair our cells and our DNA. That boosting the number of mitochondria again is probably chucking petrol onto a fire. That when we're doing this sort of mitochondrial optimization, you have to think about, well, what is the end goal I want from this, like with the brain optimization? If I increase the number of mitochondria in biogenesis, so I create more of them, I'm now creating more factories for energy production or neurotransmitters or hormones. But I'm now also increasing the number of guys that make pollutants in my body. So whilst I'm getting a massive benefit from having more factories to make all this material, they're creating a lot of waste. That can I accommodate the waste that they're creating, or do I have the practices to accommodate recycling the waste that they're creating? And then you have the other side of it, which is improving the efficiency of the mitochondria, which is how they're able to utilize glucose or fatty acids for glucose oxidation or fatty acid oxidation. And that then comes back to what's called oxidative phosphorylation, where we're using oxygen to burn glucose or burn fatty acids and beta oxidation to feed into the electron transport chain. That if, again, as the mitochondria efficiency to create more energy improves, in theory, if we had a supported system of antioxidants to help keep the fires under control that are happening from the energy creation, improving their efficiency is probably a no-brainer, because you're improving how they're producing the energy in a more efficient manner. But then that relies on how your body is able to metabolize fats and glucose and bring them into the cells for the mitochondria to use, which then goes back to like insulin sensitivity and how you digest and transport fats. That it's not just straightforward that you get all these benefits. Like you take SLU, you're stimulating more mitochondria to be made from the estrogen receptor related alpha stimulation, or you're improving how energetically efficient they are at making energy inside the mitochondria. If overall the mitochondria are being poisoned, to speak, or dysfunctional, it just doesn't make sense to take something to, basically you're just keeping things in a level playing field. You're putting something in that is getting you nowhere really overall, other than wasting money, in my view. That you'd want to then try and remove the source of the pollution that's poisoning the mitochondria, if you want to put it that way, and then look at making them more efficient or giving you more energy out of it.
Gotcha.
And that's, it's where we have to be very careful when we're talking about all these crazy things, and people look at what I've done with this sort of trifecta and the amazing results that came from it. It was because I had to think about, do I have these underlying support pillars to allow me to push hard on these guys? Most people will just look at the supplement and think, I'm going to try that, without taking a step back and thinking about the consequence of, if I do this, what is going to happen at the end? And again, it comes back to, again, the B complex. You have to know what's going to go beautifully or what's going to go tragically when you do these things. That we're talking about something that can dramatically change a bodybuilding prep. And I proved that last year, where, you can prep on very little, to speak. You can get away with eating 3,400 calories on a training day, a body weight of like 202 pounds. You can get away with 20 minutes of cardio and 10,000 steps. That's on the surface of it, it looks like an amazing bodybuilding prep. It's like, that's some per person's off season that you're eating the food for, because you've understood that I've built this pillar of supporting these guys, and once I turbocharge them to speak, they're going to give back positively, provided I keep up with them, provided I keep feeding them. So again, this is where, when we're looking at how we burn body fat and fatty acid oxidation, one of the primary things that helps fuel fatty acid oxidation is glucose metabolism. So this is where, for like in a prep, and this is why it never made sense to me, if your bodybuilder is consistently restricting calories, expecting, well, from carbohydrates, expecting your mitochondria to burn fatty acids more efficiently because you've created this energy deficit from carbohydrates that are fueling the mitochondria in a certain aspect to produce energy that feeds into fatty acid oxidation, you're basically blunting your ability to burn body fat. So you then have to view, am I fueling these guys adequately? Am I eating a high carbohydrate diet? Am I doing everything from a NAD, like the vitamin B1, B2, B3 perspective, magnesium, all of these basics that I've never really spoken about, that you have to understand this bigger picture before you start putting all these guys in. But once you do have those guys in place, in theory, these things on paper work like magic. Okay. It's not magic, it's playing off biology, but a guy under 30, I'd be saying, to me, if you're very curious, I'm not going to stop someone's curiosity for a what if, but it's really unlikely that they're going to require it. If they're looking to, I'm going to use the word like cheat. If they want to look at like cheating a prep, if they have everything in place, like what we talked about, well then you've got nothing to lose other than your own personal risk and your own financial risk of getting the products and spending money on it. That I just, if someone came to me and like, I want to try this stack, again, it comes back to the basic questions of like, what's all the foundations underneath? It looks great. You know, it's this new fad to speak, but it doesn't necessarily mean that they require it on the surface level. So it's just, I'm always just very cautious.
Okay, cool. And I guess that would be another cool argument too for, I guess, advocating having a little bit more of a balanced diet when you're prepping, when you're cutting, rather than there is a lot of people that will crash their carbohydrates really low and keep their fats fairly high. I know originally it's a better method for a hormonal perspective, especially if someone's not supplementing hormones. But I guess if you're a bodybuilder, it's not always a terrible decision to go the old classic bodybuilder route and have some fairly low fats and a more medium carbohydrate intake.
I mean, when we're enhanced bodybuilders, the whole fat intake, yes, you need a level of fat intake for cell membrane repair. So your cell membranes are made of fats. You need a certain level of fats for brain health and for brain energy on top of carbohydrates. Which
I think some people can definitely tell whenever they're crashing their fats a little bit too low. They can feel that when their fats are too...
I mean, the way I set up my prep last year was on average, on a training day, I had 390 grams of carbs. My fat intake, I think, was 45 grams, and my protein was about 280, 290. And that was at a body weight of, the stage pictures in the end, I was 87 kilograms at weigh-in, which is like 196. But all my fat came from fish oils or supplemental sort of sources of fat, like macadamia nut oil. I kept all my protein like lean sources. With lactose intolerance, we have a vegan isolate product. I use that as my sort of protein shake. But I've always leaned into like fat intake strictly from polyunsaturated omega-3. So I'd have one meal, I'd have 6 to 8 capsules of our omega-3 fish oil products, and that's giving you 3 to 4 grams of EPA and DHA, which is what we sort of look at as a clinical requirement for EPA intake. We have another like chewable fish oil product. I do another serving of that at the next meal as a fat source with maybe 5 mils of macadamia nut oil. And then the next meal, again, some omega-3 fatty acids with the macadamia nut oil. And that was pretty much it. That was my fat intake. And the omega-3s were playing into brain health, into membrane health. But like that works for me personally. Some people who take in a massive amount of fish oils can run into blood clotting risks. The cell membranes can become very, what would be the best way? Very flexible, so they lose their rigidity. So there are risks to using a lot of omega-3 fatty acids as a supplement.
Yeah, that's what I was about to ask. Is there like what's like a number that you would put a cap at?
To be honest, really, a very good friend. He's not as active on social media anymore, but Ben Cant is a very well-known Australian nutritionist. And his perspective was, it's like 1 capsule of omega-3 fish oil for every sort of missed serving of oily fish per week. Don't quote me exactly. He has some good content. If people go to his page, he's very interested in omega-3 fatty acid intake and its effects on health. He's a big proponent on like eating mackerel, sardines, fish that are going to provide you with your omega-3s as opposed to supplementing. That the other side of it then to pay attention to is not all fish oils are created equally. That the total oxidation, the actual amount of the oil that has been damaged by oxidation is important, because if you're buying cheap supermarket fish oil to pick on somewhere, it might look like a bargain. It might fill some nutritional void, but the oxidation of that product could be quite high. There's been research papers done on commercially available omega-3 products. They analyze the total oxidation of these things that are on just regular retail shelves. And the oxidation values of some of them are like 40 and 50, that above 26 is the acceptable limit.
One I really recommend is, the one I'm taking currently is Carlson's, the finest fish oil. And they also have the options that you can just get it from a bottle, so it doesn't have to be in pills, where it's a little bit more easily oxidized sometimes. And
that we've won Omega Pro, the chewable version. The Totox of that is 2 to 3. It's basically to like, as soon as the fish is caught, it's manufactured. Put it that way. That as soon as it's caught in the sea, they manufacture the oil and distill it, so it hasn't got a chance to encounter transport issues, oxidation, and it's stored obviously in I guess sunlight protected containers and everything else. That paying attention and looking at that, I guess transparency when you're buying fish oils, that pay attention, ask companies for Totox values. Like I get questions all the time of ours, have you got a Totox value? And I'll send the 2 values of our 2 products, and they are below the conformed 26, whereas other companies might be a bit hesitant to tell you that. Just bear in mind that this then is a source of oxidative stress, that you think you're taking something that is a healthy supplement, but the consequence on your health long term is something that you've not even thought about.
Awesome. Well, I think that's a good place to wrap up this podcast for today.
Yeah,
we had a record-breaking time.
It's 11:45 and at night here, approaching midnight. So
I'm sorry about that, man.
I'm like we talked about, tonight is most definitely going to be a melatonin night with the lights on here and wind down for an hour.
Oh shit. Oh man. Well, I really appreciate you for coming on, man. And I'm sure the audience does too. And if you're up for it, I have a fuck ton of questions here in the Q&A. Plus, I also had my own curiosities, things such as like discussing peaking for a show with you, and also GH. And some of these people would love to hear about more things regarding fertility, insulin, just a bunch of other topics that I think are all super interesting as well.
Be a pleasure. Pleasure as always to come on and chat.
Awesome, man. Well, is there anything else that you would like to say or promote or whatever before we leave?
No, just thank you very much for the second opportunity to come on. And if people want to, I'm sure they know where to follow me on Instagram at DeanSTM, and our supplement company, supplementneeds.co.uk. So
awesome. Well, thanks for coming on, man. Thank you.
Thanks a million.
I hope you get some rest tonight.
You too, for this evening anyway.
Later, man.
See ya.